Well, good morning, everybody. Thanks for coming. This is just so you know where you got yourself into. This is our Pelvic Pain Treatment Center Patient Symposium. We like to do these every year and a half or so, and I think we have a lot of fun speaking, communicating, and going back and forth, at least through the chat business with patients, and giving you guys some more information about what's going on in the field of pelvic pain. For those who are not within our practice, who are perhaps in different states and different areas of the country or world, I'm Dr. Robert Moldwin. I'm professor of urology at the Zucker School of Medicine at Hofstra Northwell, and we have been working in this field for many years, and we'll talk about the faculty in a little while. And we're really just so happy to be working with some wonderful, wonderful other groups today, which we'll get into in a moment. So let me just give you a little, we're just going to go to a quick snapshot overview of what's been going on over the past few years as far as patient symposiums are concerned. We started out doing this kind of lecture series for patients many years back. It's really always been run as an in-person meeting. Usually it was at one of our facilities, North Shore University Hospital in New York on Long Island. We usually, as you can see here, that's a real picture of the Rust Auditorium that we were having the meetings. We had coffee and cake, and it was really nice to just sort of see everybody in not such a clinical environment and all that. So that was a good thing. But then, of course, COVID hit, and obviously it changed all our lives in many different ways. And we went to a web-based format because we still thought it was really important to have this exchange of information. So with that, I've always, and I think everybody in our group, have been working with the interstitial cystitis associated for many years, and you'll hear more by Lee Lowry about that in a moment. But incredible, and I have to thank everybody for at the ICA getting this web-based meeting organized. But now we're really doing things in collaboration also with our Northwell partners, the Katz Institute for Women's Health. You'll see, I know we have one of the physical therapists here from STARS Rehab, and of course, Joel Stern, one of our basic researchers here with us today, and we're all from the Hofstra School of Medicine, the Zucker School of Medicine at Hofstra Northwell. So just to give you an idea of our wonderful faculty, we'll first be hearing from Lee Lowry from the Interstitial Cystitis Association, just because, well, first of all, they're running this whole show here today, which is great, and because they are an incredible group of individuals who are really dedicated to not just helping IC patients, but moving the field forward with research and education in this field. We're going to hear a video from Stacy Rosen, who's really the key person who was responsible for getting the Katz Institute for Women's Health up and running, and getting even a pelvic health consortium run through our institution, which is, we're really, really happy to see some really dedicated work and faculty dedicated to this specific issue of pelvic pain and other pelvic disorders. You'll hear from me, you'll hear from Dr. Addie Katz, one of our distinguished gynecologists, who works with minimally invasive gynecology. We'll talk about endometriosis, and Bella Grossman, a clinical psychologist at the Katz Institute, also part of the Northwell Health program, and also works in the Department of Psychiatry. Mary Hughes Johnson, again, I had alluded to Mary. She's an outstanding physical therapist who works with STARS, a whole group of different facilities where experts in pelvic pain, physical therapy dedicated towards pelvic pain are present, and are really making strides with so many of our patients. And Joel, who we've been working with for a bunch of years now. We are collaborating, looking at some of the facets of IC, which we'll get more in detail in a little while. Jen Ferriello-Molden, my wife, expert in the field of urogynecology. She's works in the field, been working for years and years in the field of pelvic pain, sexual medicine. You'll love her talk today. I looked at her slides. Quite a title. And Marina Ruzamovsky, I think we're sort of joined at the parietal lobe or the frontal cortex, someplace there, because we've been working together so long. It's a joy to work with Marina, and her expertise in the field of pelvic pain is you can't beat her. So let me give you an idea. Really important. I mentioned the ICA. I mentioned you'll hear from Lee in a moment. Really a big shout out to Mickey Mahal, who's just, oh my God, we wouldn't be here this morning without her efforts. She is the technical wizard, the organizing wizard behind everything we're doing this morning. And probably the reason we're not starting at 11 o'clock or 12 o'clock with technical difficulties. Anyhow, here's our lineup for today. We'll hear from Lee in a moment, Stacy Rosen from the video from KIWH, the Katz Institute for Women's Health. I'll give a talk about some IC gap management guidelines. We'll hear from Addie Katz on a subject very important to particularly for premenopausal women in pain, endometriosis. We hear from Bella Grossman on cognitive behavioral therapies, and Mary Hughes Johnson on the art of breathing for pain control. Joel's going to talk about issues related to interstitial cystitis and perhaps other similar conditions and autoimmunity. Jen will be talking, love the title again, lubricants, moisturizers, and dilators. Oh my. I'm sure a very detailed talk on a lot of methods, simple methods that can really have a big benefit for patients suffering with pelvic pain. Marina is going to be talking about some new things we're doing and research in the field of local bladder therapy. And I'll finish off talking about some of the research things that are going on in the field. So with that, we'll be having some Q&A sessions along the way, and then we'll conclude probably about 1 o'clock, we figure. So with that, I'm going to hand things over to Lee, and I'm going to take my leave for a little while.
While he's doing that, I'll just go ahead and start. Thank you so much, Dr. Moldwin, for bringing back this amazing symposium and allowing the ICA to be a part of it. We would like to thank the experts from the Arthur Smith Institute of Urology, the Katz Institute for Women's Health, and STARS Rehabilitation of the Northwell Healthcare System for sharing their expertise today. And we are so excited that all of you are here with us today. My name is Lee Lowry. I am the Executive Director of the Interstitial Cystitis Association. And for those of you who don't know, the ICA is the only U.S. nonprofit dedicated to uplifting lives impacted by IC-BPS. Through your donations, we create a haven of support, connecting those with IC-BPS to a network of understanding individuals who share their journey, and also connecting patients to healthcare providers who are passionate about treating IC-BPS. Contributions fuel our outreach programs, advocacy efforts, and educational resources like this symposium. It enables us to lobby for research funding and offer a lifeline of empathy and guidance. Together, we're not just funding hope, we're fostering a family where IC-BPS warriors find solace and strength. Our vision is to conquer IC-BPS and change lives. You can find us on the web at ichelp.org. And before we start, I just have a few housekeeping items. You probably noticed, but just want to make sure you're aware that today's symposium is being recorded. And we have, as Rob went through the agenda, you might have seen that we have 2 planned 30-minute Q&A sessions, one near the midway point of the day's sessions and another towards the end. To ask a general medical question, which is not personal, please go ahead and use the Q&A feature. And I'm told that we can answer all kinds of questions as long as they're not personal. So you don't need to be too shy about asking questions that might not be directly related to the presentations. The presenters will answer as many questions as they can in each of those Q&A sessions. We kindly request that you go ahead and submit your questions throughout the event rather than waiting until the Q&A sessions. And also, please watch out for the post-event survey. We'll be sharing that link in the chat during the presentation. We would love your feedback. And finally, please note that we have so much content packed into these 3 hours today that we really were unable to schedule any breaks. But please feel free to step away at any point to take your bio breaks. We'll be here when you get back. So just do what works for you. If you find this symposium to be of value, please consider donating to this month's Pain to Purpose event or sign up to fundraise. Your support allows us to continue to bring you amazing programs like this. You can go to our website at ichelp.org and learn more about how you can support ICA during IC Awareness Month and beyond. Okay, so that wraps up our housekeeping. And now I'm going to go ahead and introduce Dr. Stacy Rosen of the Katz Institute for Women's Health at Northwell Health.
Hello, I'm Dr. Stacy Rosen, Senior Vice President of Northwell Health's Katz Institute for Women's Health. The Katz Institute is dedicated to improving the health of women across their lifespan, bridging the gap between wellness and personalized care delivery. We are advancing women's health every day by providing expert, coordinated care, educating our community on prevention, well-being, diagnosis, and treatment options, as well as supporting sex and gender-specific research. Aligned with Northwell Health's mission statement, the Katz Institute is a convener and amplifier of all women's health systems initiatives focused on improving health outcomes for women, because we know that ultimately, healthier women lead to healthier families and healthier communities. The Katz Institute continues to establish itself as a national leader in the delivery of women's health care. For more information and to access Katz Institute for Women's Health resources or to join our newsletter mailing list, please visit northwell.edu/KIWH. Enjoy today's programming.
All right, good. All right, so my first lecture, I have 2 lectures this time. This will take about 15 to 20 minutes. It's entitled the ICBPS Treatment Guideline Update. So let me just move right on into this. Here are my disclosures. Most of these are companies that we're doing research with. Really, to understand the guidelines, before I really get into guidelines, I really need to go over some basics. What is interstitial cystitis, the bladder pain syndrome? And it's basically, the whole diagnosis is based upon the definition. So you can read it with me over here, but I'm going to take a little moment to just sort of tease it apart. And this is by the American Urological Association, feels that it should be an unpleasant sensation, whether that be frank pain, pressure, or discomfort, perceived to be related to the urinary bladder. And those discomforts perceived to be related to the urinary bladder really should be associated with what are called lower urinary tract symptoms. Usually they're what are called irritative symptoms, like I have to go to the bathroom more frequently because of these other issues. It used to be that to make a diagnosis, you had to have this ongoing for like 3 or 6 months. It depends upon, that sort of changes and is debated. But because we wanted to get patients, or the AUA, the American Urological Association, wanted to get patients moving through the system faster, it brought it down to 6 weeks duration. And in this case, of course, we really can't see those symptoms in the face of infection and other identifiable causes, for example, cancers of the urinary tract, stones being passed, or any other conditions that, again, that can cause the perception of bladder-based conditions. If you look at definitions elsewhere, you say you go to, again, in this case, the lower definition is through the Japanese Urological Association, see very similar definitions. So there is some harmony actually across the globe. And that's actually a good thing, because now we can, when we do research and even clinical work with patients and even see patients from other countries and back and forth, we sort of have this general concept of how the patients should be presenting. The other thing that you really have to know is that when we look at IC-BPS, interstitial cystitis bladder pain syndrome, there are two basic, we'll say, flavors, categories of them. One is the BPS, what's the bladder pain syndrome, where patients have all those symptoms I just discussed, but if we look into their bladders, we do a cystoscopy, we see a normal bladder wall. And what you're looking at on the screen is a normal bladder wall. On the other hand, we have other patients who have the true itis, the interstitial cystitis, where we see these these very defined areas of inflammation. And as you can imagine, you can just look at this, it looks nasty. And when the bladder stretches, it starts to fill. People often have a terrible degree of pain. And also the scarring associated with this may even limit bladder capacity just anatomically. Whether you can go from one to the other, we don't think so. There's no good data to suggest that. We do wonder whether there's a spectrum between these two conditions. But right now, you can see the title of this is a title of an article that we were part of a few years back, just 3 years ago, it seems shorter, but suggesting that maybe these patients who truly have interstitial cystitis, maybe this is the disease and the bladder pain syndrome is a different entity, and perhaps they should have different treatment algorithms and maybe different treatments apply to one population versus the other population. So IC-BPS, that's sort of where the name is coming from. That's the concept behind the slash mark between the two things. And now we get even a little more complicated because because there are lots of different clinicians out there and different types of professions. The pain management people, the people who are part of IASP, the International Association for the Study of Pain, have a different way of looking at pain. And they've reclassified it back in 2019. And this will have ramifications of how we look at the literature, how we even do when you come to the office, what's your diagnosis? What is the insurance company going to see? So I think from a practical perspective, I put this slide in specifically so you just know some of the difficulties that we're encountering and might get complicated when it comes down to insurance companies know what the condition is and what's the terminology here. They would actually like to see the IC-BPS term cut out. They have a different way of approaching pain and their nomenclature. They would like interstitial cystitis to come under the heading of chronic primary visceral pain. The bladder is part of the viscera, and IC, instead of calling it IC-BPS, would be called chronic primary bladder pain syndrome. And we can debate about this all day long, but suffices, I just wanted you to understand that this is what's going on in the medical community right now, people who are really dedicated to the treatment of pain of all sorts. Anyway, let's get back to the guidelines. The initial guidelines that were out from 2015 have been updated. They were updated just last year. So this is sort of fresh stuff. And really what you see in the new guidelines is really these categories, I think, really mark it off with more shared decision-making between clinicians and the patients. A multidisciplinary approach is really stressed. A phenotypic assessment is also stressed, which we're going to talk about in terms of when we talk about different types of therapies and research that's going on now. We know that not every patient is the same. Some people have different severity. Some patients may have even different causes behind their symptoms. So that really leads us to the next line down, the next bullet down, a patient-tailored approach. And also there are some specific clinical guidance items in the new guidelines, specifically with reference to Elmiron, the pentosan polysulfate sodium, and ophthalmological issues that are of concern. So let me break it down for you here. This is the algorithm that urologists now see when they look up, well, I have an IC patient in my office, what should I do? As you can see here, we just went over this. This is the definition that everyone should be working with, which is pretty broad. Okay, you can imagine there are a lot of things that might interact with these types of symptoms, lots of things that could be causing these types of symptoms. The other thing that I just wanted to make note of is a basic assessment. This portion of the guidelines has not changed all that much. We always do a history, a physical examination. We'll check the urine to make sure there's no blood or infections going on. If we think that the patient is a smoker, older patients where we're concerned about perhaps cancer being present as a cause, we might send out special testing for that. We might do what's called a post-void residual, see, just make sure you're emptying your bladder okay. Those are the basic assessments. And then we sort of divide things up into those patients who have uncomplicated versus complicated IC-BPS. So uncomplicated are the patients who basically all those other tests, the urine studies, all that is negative. They have typical symptoms. We can go on and actually just go into empiricism. We can just treat the patients on the basis of symptoms, see how they do. If they're not doing well, we can always go back. The other way of doing it is if you think that a patient is complicated, a patient has blood in the urine, a patient's not emptying their bladder out, a patient has all sorts of other difficulties that you think might require more extensive testing, as you can see over here, whether it be looking in the bladder, doing bladder function testing, or even procedures like laparoscopic procedures. That's, again, up to the clinician. The biggest concern I have, I think, and just throwing this out to the general urology, urogynecology community, is the fact that I think one step would be important is to identify coexisting pain generators. So lots of other things, we'll talk about pelvic floors, tenderness and all that, and other different types of pathologies can coexist or be the primary cause of symptoms. So it's always important to rule it out. The next portion is if you feel, this is a new thing, if you feel that the patient has those Hunter lesions, which I just showed you in the other slide, you think they might be present in any given patient. Usually these are going to be patients usually over 40, but we've seen them under. Then it might be reasonable to actually put the cystoscopy earlier up in the diagnostic algorithm, because if we identify them, we may have different things to offer the patients, such as endoscopic fulguration. That means to burn the lesions, inject them with steroids, et cetera, and even possibly, ultimately, as you can see down here, give patients immunosuppressants that can calm some of the inflammatory disease down. So that's a different, an addition to the old guidelines. The other change in the guidelines really comes down to, now you have a diagnosis. What therapies are you going to offer the patient? And I don't think anybody would argue education, the ICA, get them hooked up with good places to find information. Dietary changes, although it's not explicitly seen in the algorithm, I put it in there myself, of course, and all these things. But supposing a patient comes in with really severe symptoms, they're voiding, 5 times, 6 times per night, they're not getting sleep, they can't, it's hard to even to them to get to work, take care of kids, whatever, it's really having a terrible impact on their quality of life. Why would you just change their diet? You want to do other things. The previous guidelines really had it in a tiered form. You go from this, if this didn't work, you go to this, and then you go to this. This is more, again, you will have to try to, the job of the clinician is to figure out and to talk with the patient what's the right way, what's the right approach. Should we be working with oral medicines, medicines putting in the bladder? Again, have to think it out, but do what's best given the specific clinical presentation of any individual patient. The other thing, as you can see over here, let's see, right over here, I don't know if it pops up. Yes, it does. You see it says over here, there's oral medicines. Patients considering PPS, that's Elmron, should be counseled on the potential for eye damage. And that really comes from some data from several centers suggesting an association between the use of Elmron, again, the pentacen polysulfate sodium, with something called a pigmented maculopathy, where you can start to have vision changes, which I'm not going to, just for the sake of time, which I'm not going to get into now. But there are specific suggestions as far as if you're going to use this medicine, how to use it properly, how to use it in conjunction with ophthalmological examinations and follow-up. So that's really, I think, an important addition amongst other little changes and strategies for other medications. So that's really where the guidelines are today. I think they are really based upon research that has been ongoing since the previous iteration from 1915, also based, of course, on clinical experience. I think really, I'm not sure how much it changes our practice because we sort of have been doing this type of algorithm for years, but as far as the overall IC population and their interactions with the medical community, following these guidelines, I think there will be better streamlined patient care and hopefully better clinical outcomes. Okay, great. So next on our program is Dr. Addie Katz. I'm going to let her do her introductions, but she is one of our beloved minimally invasive gynecologists, if that is correct, who has great expertise in endometriosis. And she's going to give her thoughts on endometriosis and interstitial cystitis. So thanks so much for joining us, Dr. Katz.
Thank you so much. Can you hear me? It's a pleasure to join you today. I think that this is so important that I'm joining on vacation from Israel. Our goal is to reach as many of you as possible, to let you know that we don't want you to be experiencing pain every day, and we all want to support you and help you. So I wanted to talk a little bit about endometriosis. Endometriosis is a condition where the lining of the uterus, or tissue similar to the lining of the uterus, is implanted in the pelvis and around the fallopian tubes. The ovaries is the most common location, around the bladder, and it causes cyclic pain or constant pain in the pelvis. It's very closely related to interstitial cystitis and can coexist with interstitial cystitis. It actually affects about 10% of women, and the average age of diagnosis is 28 years. Unfortunately, there's usually a delay of up to 10 years in the diagnosis, and it's present in 70 to 87% of women that have cyclic pain. So endometriosis is a condition of the immune system. A lot of people with uteruses and fallopian tubes will have tissue similar to the lining of the uterus that is located in the pelvis. And with the activation of the immune system, this tissue grows and implants, and the body reacts to it as a foreign subject, and it can cause a lot of pain and inflammation. And we know now that chronic inflammation can cause a lot of conditions. So this condition can present with problems and pain when you're pooping, problems with urination, problems with intercourse. It's difficult to pin down, and unfortunately we don't have a test that we can easily give patients. Currently the only diagnosis is surgical. So it requires somebody to go under anesthesia, and we go to the operating room, we look inside the pelvis, we sample the tissue and see what's going on in the pelvis, and if the condition is caused by endometriosis. Endometrioma is a cyst that grows inside the ovary, and this tissue that's similar to the lining implants and creates a cyst that bleeds into itself and grows, and sometimes doesn't respond to medical treatment. They cause a lot of scar tissue and pain in the pelvis, and can also interfere with fertility for patients. And so usually we see two patients, ones that come in for evaluation of what we call subfertility, is difficulty to get pregnant, and patients who have a lot of cyclic pelvic pain and difficulty. So as we mentioned, it may present with painful periods, painful intercourse, constipation, chronic pelvic pain. It can be confused with many conditions such as pelvic floor disorders, sometimes depression, muscle issues, PID, which is pelvic inflammatory disease, scar tissue, IBS, and interstitial cystitis. And it's important to note that these conditions are not individuals. So you can suffer from interstitial cystitis and endometriosis and IBS. These are all autoimmune mediated conditions. So it's very important to talk to the physician, share all your symptoms. It's also very helpful to keep a diary and to keep track of if there's any relationship between the time of your cycle and when you're experiencing pain. A lot of times people will report that they're experiencing pain during ovulation, which happens typically halfway in the middle of your cycle. So usually 2 weeks after your period starts, and also pain that starts a few days before the period up to a week and lasts through the period. When the condition gets advanced, patients may experience pain all the time. This is an example of what the tissue may look like. It's usually these little dots in the pelvis. And because they're flat, you can't really pick them up on ultrasound or CAT scan or an MRI. Usually it requires a higher stage condition in order to be able to pick it up on some kind of imaging study. So what's the best way to treat it? It's usually related to what your symptoms are and what your goals are. And if you're wanting to improve fertility, it's a different treatment than treating it to help pain. Usually we try with medications first before we go to other ways to deal with it. So a lot of times we may offer patients hormonal management, so birth control pill or medication to stop the periods, and medications to help inflammation. So what we call is Advil, Aleve, non-steroidal anti-inflammatories help deal with the chronic inflammation. And if that doesn't help, or you're actively trying to get pregnant, or you have more advanced condition, then we would go to surgical intervention. So like I said, usually the treatment is hormonal treatment and anti-inflammatory treatment. And with surgery, usually we do laparoscopy. So that's putting a little camera in the belly button and looking around and removing the diseased tissue. 7 out of 10 times it helps the pain, but it's very important to let you know that it's has to be combined with physical therapy and relaxing the muscles and dealing with the inflammation. And surgery by itself usually doesn't resolve all the symptoms. So it's very important to find a supportive team of doctors and other healthcare providers, physical therapists, that you work with in order to improve the condition. And I just wanted to open it up to any questions that the audience has about endometriosis. So please write any questions that you may have into the chat, and I'm happy to answer them. I just think that it's very important to share your symptoms with your providers. And I know it's a frustrating condition to have pain all the time, and you need to find people who are supportive and understanding. So you may have to see more than one provider to find the right people. And that's why these webinars are so important, so you know who is out there to help and support you. So I'm gonna stop sharing my screen. Okay. So I don't see any questions specific to me right now.
Oh, we're going to have a question and answer in a little while.
Okay, I'll hop back on at that point.
Thank you.
Thank you
That
so
was
much for
wonderful.
including me.
Thanks so much, Addie. Really, really appreciate it. So our next speaker is actually through video today. She unfortunately couldn't join us. It's Bella Grossman, Dr. Bella Grossman, who's a clinical psychologist who's been working with us recently. And Bella, I tell you, we have really been, and Bella works, by the way, with the Katz Institute for Women's Health, and she's just a wonderful person. She's also teaches within the medical school and within the Department of Psychiatry. I really wanted to bring her in because, as we'll get into, as far as therapies and research in the field, this is really the stress and the difficulties and pain management. It's a multidisciplinary deal. You're not going to have one therapy. I think that's going to be a big take-home message from any of our discussions today. One thing is not necessarily going to make you feel better. Going through this gauntlet of procedures and evaluations really does take a toll, and actually just the stress involved seems to amplify pain for many individuals. So to bring someone like Bella in, who's working with cognitive behavioral approaches, I think at least in our center is long overdue. It's something that I think hopefully over the next many years, we're going to see more clinicians engaging in this area. So we're going to hear some of Bella's comments and suggestions as far as cognitive behavioral therapy for the treatment of pain. So take it away, Nikki.
Hello, my name is Dr. Bella Grossman, clinical psychologist at Katz Institute for Women's Health and assistant professor at Hofstra University School of Medicine. And I'm excited to speak today about some useful tools that you can use to help with coping with pain. And I wanted to thank Dr. Moldwin and thank the Interstitial Cystitis Association for inviting me to talk today. So I'm going to pull up my presentation to share with you, and we'll get started. So first, I'm going to talk to you a little bit about the biopsychosocial approach to pain, and then shift to a little bit of an introduction to how to identify unhelpful thoughts, both broadly and then specifically related to pain, as well as learn some ways to challenge unhelpful thoughts. So pelvic floor disorders occur when the area that supports the pelvic organs become weak or damaged, and these may result in urinary or fecal incontinence, as well as persistent pain in the pelvic walls. Some common diagnoses include endometriosis, pelvic floor tension, interstitial cystitis, myalgia, pelvic inflammatory disease. And again, given that we're here all today, we're learning more about interstitial cystitis, and it's a very common disorder. It can affect between 3 million and 8 million women, and between 1 million and 4 million men in the United States. Interstitial cystitis can also have mental health consequences. So it can lead to a decrease in physical and social activity, which can impact quality of life. There's also some evidence that co-occurring anxiety and depression can impact quality of life, pain intensity, functioning, and response to treatment. And that anxiety and depression is a very common occurrence in individuals that have interstitial cystitis. Therefore, given that there can be psychological and social implications of having interstitial cystitis, psychological or psychosocial treatments are important for managing this disease or this illness. So the biopsychosocial model of pain talks about the way in which pain is impacted by multiple factors. So we have the biological component, or again, the damaged or weakened muscles that might exist in the bladder and in the pelvic region. So that's one aspect. And then we also have the psychological aspect of of pain, which can entail our previous experiences with pain, our thoughts, our feelings, our personality, right? Ways other people have experienced pain. So all of that can impact our relationship with pain. And then there's also the social factors. So how, if we have financial stressors, how other people respond to our being in pain. Other stressors such as not being able to work or not being able to accomplish day-to-day activities. So that's another kind of factor. And all of these factors combine to impact your pain experience. And this is just another kind of demonstration about, again, the multiple layers and the ways in which they all interact with each other to impact your pain experience. And the importance of why we're going to focus on the psychological and social factors. For the biological factors, that's why you go to your medical doctors who can work with you in terms of medications and injections and surgical procedures. And then we're going to focus today on some additional psychological ways to help improve your pain. And so in order to talk about that, I think it's important to kind of recognize what happens when you have a pain condition. So for example, in interstitial cystitis, one thing that happens, right, is that your bladder sends signals through all the complicated nerves and connections to your spine. And the spinal cord then sends the information to your brain. And from the brain then takes all that information and based on, again, past experiences, different connections that exist, then sends information back down to the spine. And in the spinal cord, there is a mechanism. It's like a gating mechanism that can either the brain can send information down and cause the signals to be opened or to be the volume to be increased for that pain signal, or the brain can cause the gates to close or to lower the signal of the pain signal that's coming through. So some things that can open the gate or can increase the volume of the pain include depression, anxiety, stress, and some things that can help lower the volume of the pain signal can include positive experiences, relaxation, pacing activities, which is another type of coping skill. So again, it's so important for us to talk today about, we might not be able to completely eliminate pain, but we can try to help reduce the volume or to lower the intensity of that pain signal that's coming through. The relaxation skills is one of the coping skills that we can use to help with coping with pain. And I believe that some of my colleagues will be going into more details about the different types of relaxation skills that exist. I did think it would be helpful for me to briefly mention about one coping skill to use, or one type of relaxation skill to use, which helps to slow down the breathing. And it's called 4-7-8 breathing. And with doing the 4-7-8 breathing, what we do is we help to engage our parasympathetic nervous system, which is a part of the nervous system that helps to slow down our heart rate, slow down our breathing. It engages the part of the brain which helps us to get out of fight or flight response and to get into rest and digest. And that's particularly important because when individuals are experiencing persistent pain, what happens is that it's as if we're in chronic stress or as if we're in chronic fight or flight response. And over time, that can really be stressful to our bodies. And as we talked about before, it can increase the pain signal. So with the 4-7-8 breathing, what we do is we breathe in for the count of 4, we hold our breath for the count of 7, and we exhale for the count of 8. So let's try that together. Breathe in for the count of 4, hold for the count of 7, and exhale for the count of 8. And one more time. Breathe in for the count of 4. Hold for the count of 7. And then exhale for the count of 8. And really, different people, based on practice or based on medical conditions, might not be able to hold for the exact count, or I don't want you to get too caught up in the exact numbers. But what's important to keep in mind is you want to slowly inhale, hold it, and then the key is the slow exhale. And by doing that, again, we help to slow down our breathing and slow down our heart rate, which is good for our mind and it's good for our body. So while it might not be able to completely eliminate our pain, it is a good coping skill to help with lowering the intensity of our pain and helping us to feel more in control. And a key about relaxation skills is you want to try to integrate it and put it as part of your routine and part of your daily schedule. So when I work with clients, sometimes I'll say, trying to practice it even for 5 minutes a day, maybe when you first wake up, or maybe when you're trying to go to bed, or sometimes if you incorporate it into an activity that you're doing and you have a cue or a reminder, it can help you. So, practicing every time, taking a few nice deep breaths if you're driving and you hit a red light. Obviously don't close your eyes, but just that's a signal that it's time to take a deep breath. Or every time you wash your hands, something like that. And the more you practice, the more successful it will become and the more confident you feel in being able to engage in this skill. And here are a few additional kind of resources to help you, because sometimes it's a little bit easier when you have somebody else guiding you through. So there's a lot of great apps out there, such as Headspace, Happify, GPS for the Soul, the mindfulness app Calm. And then there's a lot of great relaxation audio websites that you can go to. We have one here at Northwell through our Center for Wellness and Integrative Medicine. That's that first link here, but also through Kaiser Permanente or the Inner Health Studio. Even if you check YouTube and type in deep breathing exercises or guided imagery, those are some keywords that you could put in, and you can get some great audio to help you with practicing this important skill. So now we're going to shift a little bit to working on how to identify our thoughts and modify our thinking, because that's one of the components to try to help with reducing the pain signal. Cognitive therapy was first created by, or one of the founders was Aaron Beck, and it's based on this belief that depression is caused by dysfunctional thinking. So he focused on depression, but cognitive therapy has been used for so many different conditions, and you don't have to have officially depression to make use of the skills. Our perceptions and beliefs affect our emotional experience of events. So, and said another way, our thoughts can impact how we feel and how we behave. So I'm going to give you an example. So for example, let's say Sue sees on Facebook that her friends have gone to a movie and she wasn't invited. So that was the event. And then she might have some thoughts such as, they hate me, they excluded me on purpose, no one likes me, I'll never have friends, which then obviously could make her feel depressed, feel sad, feel hopeless and angry. And as a result, in terms of the behavior, she might post an angry comment, stay in her room, avoid friends and family. So as you see from this circle, again, our thoughts can impact how we feel and how we behave, and they all really interact with each other. And it's helpful to become, now that we're talking about it, I think it'll be helpful with noticing sometimes these things happen so automatically, and by being aware of this, hopefully it'll bring more awareness to you, which can then help you with modifying it as well. So with the thought of they excluded me on purpose, we want to challenge some of those thoughts. So you might ask yourself, do you have any evidence that this is true, or any evidence that it's not true? Is there another explanation? What would you tell a friend who had that thought? Or we can modify the behavior. So instead of posting an angry comment or staying in the room, thinking about what effect did that behavior have on our situation? Is there something healthier that you could do, and what would have made you feel better? So for example, maybe calling a friend or going yourself to the movies, that could have helped you to feel a little bit better. So in trying to modify our thoughts or modify our behavior, it could help how we're feeling. And so the same thing with chronic pain and trying to figure out ways to cope with pain. So when you're feeling in pain, you might have certain thoughts, certain negative thoughts that come into your mind, such as assuming the worst case scenario, like my pain will never end, or feeling like I can't handle the pain, there's nothing I could do about it, which would then make you feel sad or worried. And then you might isolate. You might not want to have to deal with anybody or talk to anybody else, which then can have an impact on our pain by making us feel even in more pain, and then the cycle continues. So again, just to summarize, something that we can do is to reframe our thoughts. And to reframe our thoughts, you might want to challenge your thinking by asking yourself, do I have any support for this idea? Is there any evidence that is against the idea? What's the worst case scenario, the best case scenario, or the most likely scenario? And what would I tell a friend in a similar situation? And by asking yourself those questions, you might then be able to create alternative self-talk. And I have some pain-specific examples on the next slide. But also I just wanted to mention that sometimes it's also helpful to be thinking about this idea that sometimes, because our brain gets so much information, our brain takes shortcuts and it develops some healthy thinking patterns and unhealthy thinking patterns. And some unhealthy thinking patterns that a lot of people engage in is to sometimes think about things in black or white or all or nothing, to use extreme words such as always, never, or should, or to use emotional reasoning. So it's feeling a certain way means that something must be true. And that's going to come in handy in terms of trying to help us reframe our thinking when we're in pain. So again, pain thoughts, we want to find a different way to respond. The goal is not to create an unrealistic picture of situations, but a more accurate and balanced perspective. So some pain-specific unhelpful thoughts might be, when my pain is bad, I can't do anything. And so after challenging your thoughts and checking to see if you're engaging in any unhelpful thinking patterns, you might come up with this new, more helpful coping thought, which would be, even when my pain is bad, there are still some things that I could do. Or for example, I can only be happy if I'm pain-free. A more helpful thought could be, even if I'm in pain, I could still be happy. There's always something I can do to have a better quality of life. Another one might be, when I feel useless, I am useless. So again, that's that emotional reasoning, unhelpful thought, thinking pattern. And so a more helpful thought might be, even though I can't do all the things I used to do, it doesn't mean I can't do anything. So I know I threw a lot of information out there at you with regard to ways to change our thinking. Just like any other kind of new thing that you're learning, it does take time and it does take practice. There are a lot of good books out there to help with learning more about this if you're interested. So there's the Feeling Good, I believe Feeling Good Handbook by David Burns. There's a book called Full Catastrophe Living by Dr. John Kabat-Zinn, who is one of the founders of mindfulness based treatment. There's the Pain Management Workbook by Dr. Rachel Zoffness, and there's Living Beyond Your Pain, which also incorporates cognitive behavior therapy and also some acceptance and mindfulness-based approaches by Dr. Joanne Dahl and Tobias Lundgren. And so if you also need additional supports, there are lots of different therapists out there that could be of help as well. If you liked the approach of cognitive behavior therapy, you can check on the Association for Behavioral and Cognitive Therapy website, which is www.findcbt.org, or you can check out Psychology Today to look for a therapist there, or call your insurance carrier and ask for a list of providers, and you can ask about whether they have experience with treating chronic pain or experience with cognitive behavior therapy. So thank you so much for your time and attention. I hope that it was helpful and that it's opened your mind to some additional possibilities of ways to cope with pain. Thank you.
Great. Wow, that was my breathing. I'm concentrating on my breathing right now. We see in clinical practice something which I'm sure some patients have heard about already, catastrophizing thinking. And that's sort of a process that we see with all facets of pain, where there are some patients, it's hard. It just wears you down. It's a process where you start to ruminate, actually, because you just ruminate over the pain. And then then there's this magnification process that goes on where it really starts to take over your life. And then the final level is hopelessness. And it's tough, as I say, pain, especially any form of chronic pain, can drive you down, and people fall into this type of thinking process, which tends, unfortunately, there are a lot of studies that show sort of then further amplifies the pain that's going on, and then the quality of life. And you can see the vicious cycle this whole thing sets up. Cognitive behavioral therapeutic approaches have been found to be very good. Not just, this is what Bella was talking about, it's not just applies to pelvic pain, but all sorts of pains, lower back pain, chronic headache, vulvar pain, the pains of prostatitis syndrome patients, and so forth. So these are really important principles to keep in mind, and not everything is just putting medicines in a bladder or burning bladders or taking oral medicines. A lot of these other approaches, these multifaceted approaches, are really important for patient care. Sometimes, I saw in Bella's discussion some of these apps that are available, and just as a personal thing, I tried, because I think meditation is a good thing in general for people to embrace. And I tried, I think it was Headspace or one of them, and I thought it was awesome. I really did. It's 10 minutes, 15 minutes or whatever. But the problem, just from a practical perspective, is that you have to, I would find I would sit down and then something's always going on around me. I have some other project to do. I can't tell you. Again, life is busy. And I found that not so easy for me to do it. I think the take home message there's some people who can do it. There are some people who really do need to be seen by a mental health professional, or simply get out there and find a course in meditation or some similar approaches to work with some of these breathing issues and so forth. And to take this one step further, we're going to hear a lecture from one of our wonderful physical therapists, Mary Hughes Johnson, who will be talking to you more about the art of breathing. I'm actually interested to hear Mary's live, so that's really good. So we can get some contrast to perhaps Dr. Grossman's discussion. So take it away, Mary.
Great. Let me share my screen. And I hope everyone likes breathing, because we're just going to talk about it for a little bit longer. So I'm really focusing on
Mary, sorry, you want to, if you could, there's a little button on the bottom to share the whole screen.
Oh, did I know?
If you go along the bottom portion of you see the sliding bar over there on the bottom?
Here.
Yeah, and just Yeah, hit that one. Yep, yep, you got this,
Perfect.
there you go. Perfect.
Thank you.
Mhm.
All right, so the art of breathing for pain control, and I'm going to be talking about diaphragmatic breathing. So just to go over a little bit of anatomy, benefits, and then a little technique and practice for everyone. So just for anatomy, the abdominal pelvic cavity is down here. So the top borders is going to be your diaphragm. Anterior, so the side and front border is your abdominal muscles. The back is going to be your thoracolumbar fascia and dorsal muscles. And then the bottom is your pelvic floor. So you can really see, kind of getting a little bit more into it, when you are breathing and your diaphragm is moving, all of these body parts can be affected. So the diaphragm has multiple roles. It is innervated by the phrenic nerve, which also has a connection to the vagus nerve, and that can affect the entire body. And that's why it is so helpful in full body relaxation. When, like Dr. Grossman said, when you are in this flight or fight pattern, your body is like ongoing and it can't stop. And we really want to get back to that rest and digest. And often with patients with pelvic pain or bladder syndrome pain, they often have maybe bladder and bowel symptoms involved. So in order to go to the bathroom, they need to be in this rested state. So the diaphragm controls postural stability, defecation, micturition, and parturition. So it has so much involvement in every aspect along with breathing. And then kind of my area of expertise, the pelvic floor muscles. So they do so many things. They support the organs by maintaining intra-abdominal pressure. They assist in bladder and bowel function, helping maintain continence and proper evacuation. They can enhance sexual function and arousal. They can assist in postural stability when standing still and also in motion. And they work as a sump pump for the circulatory system, assisting in lymphatic fluid drainage from the legs to the heart. So, benefits, they help boost blood. Diaphragmatic breathing can help boost blood oxygen levels. It allows massage of inner organs because there's so much movement within the muscles. And again, it can stimulate the vagus nerve and can help decrease stress and anxiety. And how they measure the decrease of stress and anxiety is through blood pressure, respiration, cortisol levels, and this DAS-21 questionnaire. And if one thing I thought was very interesting, and I've used it throughout practice, but it was nice to see it in an article, is that a lot of patients who have any kind of issues with incontinence, they often have a hard time activating their pelvic floor muscles. They're unable to isolate it, or they end up holding their breath while they're trying to perform a Kegel. Just by doing diaphragmatic breathing, because you are activating the pelvic floor muscles, it can show improvement in incontinence. Because even though you're not thinking about activating the pelvic floor muscles or lengthening them or shortening them with a concentric or eccentric contraction, you're actually doing it just by breathing. So what are diagnoses that can benefit from diaphragmatic breathing? So basically everything, but specifically to this talk, any kind of pelvic floor dysfunction, including pain, bowel symptoms, constipation, frequency, urgency, any kind of urinary symptoms, again, incontinence, frequency, and urgency, really getting that body back to a relaxed state. And the technique. So for visuals, it's nice to see the muscles all work together. So when you take a deep breath in, your lungs fill up, your diaphragm goes down, and then your pelvic floor elongates. When you exhale, the diaphragm returns up and the pelvic floor performs a concentric contraction. So let's try it. So get into a comfortable position. Some people are more comfortable sitting down, laying down, really, however you can just be comfortable. You're going to place your hands just right on your ribs. And you want to relax your mouth. So keep your jaw and mouth just open and try. It's really hard to get somebody to relax by using the word relax. So really just try to get comfortable and keep your face soft. Now you're going to take a deep breath in through your nose. With your hands on your ribs, you're going to try to feel everything expand. So you want to breathe in. And then exhale through your mouth and let your ribs return to their resting position. So I know Dr. Grossman talked about her 4-7-8 breathing. I try to start with like just super easy, really don't focus on a count of anything, just focus on doing something slowly. So again, you want to even sometimes closing your eyes can be helpful. You want to breathe in through your nose, really feel your rib cage and your belly expand. You really want that movement out of both areas. Most of us tend to be shallow chesty breathers, so we don't get that movement of the diaphragm when we're taking a breath. I often tell my patients if they have babies around, like look at how babies breathe. They're all belly. Like we want to get back to that. We want to really get back to like that nice movement, getting everything moving a little bit better. And that automatically helps with just relaxation of the muscles. I also am all about function. Patients often have a really hard time with constipation, urgency, frequency. So having them perform diaphragmatic breathing while they're on the toilet can be extremely helpful. Just a lot of people tend to rush in and out of the bathroom. So I usually make people set a timer. Give yourself 2 minutes just to sit on the toilet, see if it can help you get your muscles to relax a little better. It'll let you evacuate a little bit better, and then you can move on with your day. So I think the most important thing is just really incorporating diaphragmatic breathing into your daily routine. And I think it's just finding a position that's most comfortable for you. I'll always have patients try it before they go to bed at night. So if they fall asleep while they're doing it correctly. And that's all I got.
Mary, that was wonderful. Thank you so much. That was really great. And also, I like, it's great to have both you and Bella actually, because everyone obviously is going to sort of adjust themselves to what's best for them. It's like nice to have, some different approaches, and it's one of the wonderful things about these conferences. So thanks so much for and the other neat thing is because, we all sort of think when we send patients to specialized physical therapy, pelvic floor physical therapy, this is all hands-on, manipulation or machines that do biofeedback, different types of technologies. Everything's muscle, muscle, muscle. But a lot of these approaches are really so important. And I'm always emphasizing to patients, you can't go to the physical therapist and expect that, because I have a lot of patients who come to the physical therapist, they say, I feel great. And then after X amount of time, all of a sudden, well, if you go out of the physical therapist's office and you're a shallow breather or you're tight, you clinch up again, you're just, you have to take the messages that, you get in the office and you have to bring them to your home, right?
100%.
So it's not just a one-shot deal. It's education, and breathing is so much a part and parcel of it all. Okay, well, we are up to question and answer time. So I have a list of questions that have been amassed over the last I guess, hour or so. And you can still pop in questions anywhere along the way. Anybody, again, we'd like to keep them not about yourselves. We'd like sort of general questions so that everybody can benefit from this. The other thing is, you heard some discussions like Mary and Dr. Katz. You don't have to always ask us just questions about the actual lecturers. So we're up and ready to answer questions just in the field of pelvic pain and all that. So what we do in clinical practice. Okay, so I have Jen here also. We'll be talking later on. So let's start off with some questions here. All right. Here's a good one. Maybe we'll do this since you're here. Does IC or PFD, pelvic floor dysfunction, cause back and leg pain? Mary, you want to take that?
Definitely possible. It's very common. So abdominal trigger points can refer to pelvic floor and vice versa. And then you can also have hip pain and back pain can also, it could be like chicken or the egg syndrome a little bit when it comes to pelvic floor dysfunction and pain. It's like what could be causing the pain, but they could all be associated with pelvic floor pain and dysfunction.
Okay. Just one addition to that. Yeah, I also completely agree with that. There's some very interesting some research. Actually, one of my old fellows at our institution, who's at Hopkins right now, Dr. Haredi, was actually patients who sensed that they had bladder pain. They ended up they found out that their bladder pain wasn't actually bladder pain. It was based upon tightness and tenderness of the muscles of the abdominal wall. And in fact, when they divided the nerves that went to those areas, their pain went away. So yeah, you can misinterpret bladder pain as well. So these are, that's the detective work in medicine. So that's what we do, and that's what you do. And that's, these are things you learn just, again, by seeing patients on a routine basis. Okay, let's go to another question here. I have well, this is not I, we'll make this a general question. Constant burning at the openings of the urethra and vagina. The IC is in remission. We see this very much, and there's no pelvic pain, no urinary tract infections. Could it be a recurrence of the interstitial cystitis? So here's a patient who has urethral vaginal pain. It appears that the IC is in remission. Could this urethral and vaginal pain be related to a recurrence of the interstitial cystitis, especially since this patient had pelvic floor physical therapy? So what are the things you think about, Jen? I know this is right up because we do this a lot. So let you take that one.
I would think that somebody would need to check the vulva for any kind of vulvodynia. I mean, we do know during embryology, when the urogenital sinus develop, the lining of the bladder, the lining of the vagina, and the vulva come from the same embryological cells. So sometimes, you know, you can get referred pain in your vulva, vagina, or vice versa. If your vulva is flaring, you can get referred pain in your bladder. That being said, I think it's always good for somebody to actually do a really good, thorough exam of the vulva.
Okay, here's another question here. I watched yesterday's pelvic floor webinar, and there was some discussion of the gag layer of the bladder. I mentioned aloe as being a good one, especially if you had Hunter lesions. And should this patient? So basically, essentially, this is a question that involves the use of aloe vera, perhaps other supplements and all that, as far and gag layer of the bladder. I mean, to my knowledge, I don't know. There's no question. We have many patients who use aloe vera products who have interstitial cystitis. Whether they're achieving any type of improvement on the basis of changing in gag layer, I don't know of any specific data that suggests or shows this. But I will say that there are therapies that are out there. They're really embraced overseas in Europe and also in Canada, where installations typically involve putting medications that theoretically coat the bladder. They augment what's called the gag layer, the glycosaminoglycan, or what's called bladder surface mucin, that is present and is thought to be a protective lining for the bladder, prevents the absorption of nasty things like ions like potassium, like urea, and other substances from getting to those nerves and actually starting an inflammatory process. So by supplementing them, either by putting it directly in the bladder, theoretically by taking it by mouth, at least a purported mechanism of action of the Elmiron, the pentasand polysulfate sodium, there can be some improvement. The typical agent that is used in the US mostly has been heparin. Heparin, as we know in medicine, most of medical people know, this is medical people should know that heparin is an anticoagulant. But it is very similar in molecular structure to something called heparin sulfate that coats the bladder surface. And when we put it in the bladder, the heparin sodium, that anticoagulant, doesn't seem to have any anticoagulation properties, but what it does is it theoretically coats the bladder. So that's typically done and put into solutions that are put into patients' bladders in the United States. There are, up in Canada, there's something called cystostat. I think there's a hyaluronic acid, another glycosaminoglycan. It's approved in that country, and in Europe, many other glycosaminoglycans are instilled directly into the bladder. But as far as an oral one, the only one that has some research behind it would be the pentasand. Aloe, not really sure. I mean, I'd like to think it might have some effect like that, but we don't know. Let's see. Oh, and that actually answers a question about hyaluronic acid. There we go. All right. Let's go to this one. So there's a question on tap water and being treated to the point where it smells like chlorine, and obviously we're always telling patients to maintain hydration, which we'll get into that. But what can you really do? That's a tough one. I'm gonna do a reach out. Marina, you want to try that one? What would patient comes to you and says that their water looks a little toxic? What do you tell patients?
Great question. I actually am not sure what to say. I'm sorry. Help me out.
Yeah. I mean, I don't think there's any great answer to the question. I mean, there's no perfect answer. I mean, the way I would look at it is if you really have problems with drinking water and you do feel that drinking that water is causing symptoms, and you've tested it back and forth, where, for example, with some of the other hydration products out there, we'll say. Zero water?
The filter, it actually has, you can test it for any kind of particles in there.
Yeah.
You test it like once every 2 months or something.
So there you go.
Yeah.
So, I mean, if you're really just like any food or beverage, I mean, obviously I would consider, moving to some other source. The other possibility is to use, I guess, I would think about some type of, bottled water, or as you say, some type of a filtering mechanism that might be able to take some of these things out of the water. I think this actually goes beyond, to be honest with you, I think it goes beyond IC and bladder-based pain. It goes into just general health. Again, we're on Long Island.
I don't drink the water.
Yeah. So we're a little nervous on Long Island to begin with for other reasons aside from from pelvic pain. But I think it's a great question. It is a dilemma for many people. But I think just thinking about it, just marching through, some type of filtration system sounds reasonable, or else you're sort of stuck with some other source for water. Okay, let's go on to another one. But yeah, okay, this is actually what is Dr. Katz still, is she available?
Yes, my son may interrupt.
So good, because we got a few for you that are I'm not going to be there. So with ovaries and uterus removed, can you still have pain?
So pelvic pain after hysterectomy does significantly decrease. but may still occur. Usually it's less than like 2 to 3% of the patients that will still experience pain after removing the uterus and the ovaries.
So when you remove the ovary, and this is patients with documented, obviously, endometriosis.
Yes.
I'm just curious, do you see
Correct.
just as a question for me, in terms of when you're doing a laparoscopic excision of these endometriomas, do you think there's any correlation between the extent, the volume of disease and clinical results?
Unfortunately, there is not a direct correlation. Somebody may have very few lesions and have a lot of pain.
Okay. I have another question just because it seems to be a lot of
And other
endometriosis.
tissue.
Oh, sure.
Yeah, and not have a lot of pain.
Do you also, do you feel?
Can you hear me?
Sorry. Got the whole family chiming in there, right? And by the way, thank you so much for coming today out of your vacation, and that is just above and beyond. And that's obviously why everybody,
I am so
why everybody loves you over here. As far as radiographic imaging, is there any specific like MRI, CAT scan, what do you do in your workup of patients beyond looking in with a laparoscope? Is there something you do before you go to laparoscopy?
I usually do get MRIs because that's the most sensitive test that we have. It will identify lesions with a thickness of 5 millimeters, so 1/10, 1/8 of an inch. But again, you can have flat lesions, so don't get discouraged. Even if you have a normal MRI, does not mean that there's no reason for the pain, but it does help us plan for surgery. So I do get MRIs on the patients.
Okay, great. I'm going to get a lot of these because please send in those things if you because we have two times to discuss things with 2 question answers, but I'm gonna let Dr. Katz get to her family in a little while. Let's take a look over here. Let me just we did have one other question. The question is, does endometriosis, a simple question, endometriosis, does it go away after menopause? Are you cured?
So the lesions, if you don't go away, but they become inactive, and then the inflammation goes away. So it does resolve the symptoms a lot of times.
Okay, great. Here's a question from one of our participants, our attendees from India. So let me just take a look. Severe bladder spasms a week before my menstrual cycle. However, there's no indication of endometriosis. I'm not sure what that, or what do you think's going on? Do you think, in other words, do you think the menstrual cycle has a great,
I would ask if the person, did they have surgery? It can be related. If it's so cyclic, it may be endometriosis related.
Okay. Let me ask you a question, just because, just a general question from clinician to clinician. What's your experience in patients who come into your practice with endometriosis-related pain? What's their journey? I mean, are they seen by many, many clinicians beforehand? Are they sort of blown away by other gynecologists? What's your sense of what comes into your practice? Because I know you do so much work in the field of endometriosis.
So I'm sure their journey is similar to patients with interstitial cystitis. Many patients have to self-advocate. They have to go to multiple providers to find answers. You have to find somebody who would listen to all your symptoms and try to put it together. It's a lot of detective work. And patients have different symptoms. because it's the inflammation that causes the symptoms. So like you were saying, it can be abdominal wall symptoms, but the lesions are located elsewhere. And it's a lot about listening and working together, doctor and patient together. There's no magic pill. It takes time, and
Right.
it takes a lot of patience to get improvement. So I'm sure they act very similarly. And then you may have both, but it's a lot of patience and work, and you have to count all your small wins. Every small win counts. If you feel 10% better, then you're feeling 10% better. That's great. And every day, every month, every year, you may feel a little bit better. And as long as you have a good supportive team, that's what counts.
Right. Well, listen, thank you so much. We all appreciate your hanging out with us actually your evening, our morning. Again, enjoy your time in Israel, and we'll look forward to seeing you when you come back home. Okay, we'll talk more.
Thank you so much. I'm sorry for the
Thanks
shouting.
again. Really appreciate
Thank you
it.
for including me. Thank you.
I think we're gonna do
Bye-bye.
one or two more questions, and these are great questions. Oh my God, some people are just so insightful. And then we're gonna get to Dr. Stern. This is an important one, I think, maybe for men. Can men benefit from pelvic floor pain exercises for IC? Is it the same for men and women? Maybe Mary can tackle that one.
I would say yes. It's
General question. You can frame it however you wish.
I feel like when people say exercise, like I automatically think of like Kegels, and often they are not the right thing to do when you're having pain. But I would say there's no difference in like men versus women with pelvic pain. It's really the presentation of the muscles and the structures versus sex or gender.
Okay, great. And let me just see one more question. I saw one. Let me ask, Marina, why don't you take this one? Can vaginal atrophy affect IC symptoms?
I'm here. Yes, absolutely. Atrophic vaginitis plays very important role in adding pain to patients with interstitial cystitis. As all of us have said before, the approach to IC bladder pain syndrome is multifactorial. I usually touch the tip of the iceberg with topical estrogen preparations for atrophic vaginitis, and beyond, I send to my very dear friend Jennifer Ferriella for.
Well, I guess we'll talk a little bit about that, a little bit, I guess, in a little while. All right, great. Thank you very much. And we're going to move on in the little program to one of the nicest and smartest people I know, Dr. Joel Stern, who is a professor of, how many things can you be a professor? He's in the departments of urology, neurology, molecular medicine. Joel has been working and collaborating with us for, oh gosh, he's got to be 5 or 8 years, something like that or more. Looking specifically at various forms of bladder inflammation, specifically interstitial cystitis. Anyway, I'm going to let him introduce himself again, and he'll be discussing something that many patients actually walk through the door asking about: is what I have, is this related to some type of autoimmunity? What's going on here? So thanks again so much for coming to speak with us today, Joel.
Thank you. Thank you so much, Dr. Molden, for having me. I'm going to talk about IC-BPS as is it an actual autoimmune disease? Does it have a lot of characteristics of an autoimmune disease? Next slide, please. I have no conflicts of interest. Next slide. So IC-BPS, the majority of IC-BPS patients have no abnormality of the bladder on the surface. This is just showing 2 images from a healthy bladder. On the right are 2 images of depicting a Hunter lesion. And there's a subpopulation of individuals that have focal regions of gross inflammation called the Hunter lesion. Next. So patients with IC-BPS have a higher frequency of autoimmune diseases, such as IBS, irritable bowel syndrome, fibromyalgia, rheumatic autoimmune diseases such as systemic lupus erythematosus, or rheumatoid arthritis. Next slide, please. So the immune system is here to defend us, to defend the body against pathogens. And next slide. Overall, this is just an image showing two immune cells interacting with each other, and several groups have shown the importance of the immune system. And it relies on what's called this a receptor ligand interaction. So there's an antigen that always, it's a protein, a little piece of a protein that drives all inflammation. And it's an essential way to induce an inflammatory response. Next slide. So what is an autoimmune disease? Next slide. So it's basically where the immune cells fail to recognize your tissue as self, causing them to attack and destroy a tissue. Next slide. So how many are there? Next slide. There are over 100 known autoimmune diseases. So if you name the tissue, there's an autoimmune disease or multiple autoimmune diseases associated with that particular tissue. Next. And next slide. Yes. So there are 50 million people in the US that have this. So is this equally distributed among men and women? Next slide. So actually women are more affected than men when it comes to an autoimmune condition. And next slide. But it depends on the autoimmune disease. So for instance, if we're talking about Sjogren's disease or systemic lupus erythematosus or scleroderma, those mostly affect women. But when we start to talk about multiple sclerosis or sarcoidosis, ulcerative colitis, diabetes mellitus, it moves towards a 1-to-1 ratio. Next slide. So this is talking about the genetics of the autoimmune disease. And next few slides, it's not about a bad gene or a bad environment. It's just a bad interaction between the genes and the environment. Okay, and next slide. So what drives an autoimmune response? So usually it takes several signals or stimuli, such as, and next slide, there are outside elements such as poor eating habits, fast food, high salt diets have been shown to induce immune cells such as T cells, certain T cells, to cause or be implicated in autoimmune diseases. Sun radiation, smoking, vaping, all of these actually were shown to be initial stimuli to induce an autoimmune response. And also viruses and bacteria are also implicated. Next slide, please. So if we have to think about the etiology of an autoimmune disease, there has to be several components that drive an autoimmune disease. So it's not just one thing, it's not just one hit, it's multiple hits from multiple angles, such as the genetics. Does the patient have the genetics? The gender, are there sex hormones or sex chromosomes? And next slide, thank you. External triggers such as diet, stress. We heard about this throughout the whole webinar. Diet, stress, sunlight, pollutions. And there are random variables such as T cell receptors. This is the immune system, where the immune system influences the autoimmune disease. And if I had to put unknown factors, that would be the largest circle, because there's so many unknown factors that contribute to an autoimmune disease. And next slide, please. So in order for the immune system to properly balance, there has to be what these things called pro and anti-inflammatory markers or cytokines that sort of balance the immune system. And next slide, when there's an imbalance, there's a skewing towards the pro-inflammatory phase. And a lot of patients with autoimmune diseases are skewed towards a pro-inflammatory cell profile. Next slide, please. So it comes up with a few questions of what are the populations of these immune cells that are found in the Hunter's lesion that's contributing to pathology? And are these immune cells responding to some antigen? Next slide, please. And thank you. And the Hunter lesion is obtained from the bladder. They're more skewed towards a B cell subtype. So here in the panel, we just see on the left side is an unaffected control subjects. So these are our bladders that were biopsied and analyzed for the presence of immune cells. And on the right, those are biopsies taken from patients that have Hunter lesions. And you can see that there are these cells, mostly skewed towards B cells. Plasma cells are B cells that secrete antibodies, as well as B cells in green are just, and red, those are generally just B cell populations. The T cells are in blue. Again, all of these populations were significantly increased, sixfold compared to the unaffected controls, suggesting that there's some inflammation that's clearly happening in the bladder. Next slide, please. So in order to figure this out, we needed to find out if there were specific immune cells, such as the B cells and T cells, and if there are certain subpopulations involved in causing the Hunter lesion. Next slide, please. So what we did is we did a lot of sequencing. We took little biopsies and then did single cell sequencing isolation. Next slide, please. And what we found is we found specific B and T cells at the site of the Hunter lesion that may be contributing to pathology. Next slide, please. And what we did is we found the same populations that we use using other methods. So in research, we always have to use multiple methods to find, to see whether our findings are accurate. And we found a large subpopulation of B cells that were present. Next slide, please. And what we did is we compared these populations, and we found, if you just look at the red dots, these are from 2 different patients, and we found overlapping. We found the same B cells that were present in patient 1, IC1, that were also in patient IC2. So this was extremely surprising. Next slide. This really doesn't happen by chance when you find these random clones. So it suggests that the B cells are responding to some sort of antigen that hasn't been identified yet. Next slide, please. So how do we fit the puzzle together? Well, we started with all of these immune cells that we found using multiple techniques, and we know that they were detected in the Hunter lesion of multiple patients with this condition. Next slide, please. So if we had to piece everything together, how does it all really work? How does the immune system contribute? Well, we were talking about the genetics. So here we actually found recently that HLA-DQ is just a specific MHC that presents an antigen to T cells. Next slide, please. And then it would activate T cells, and then the next few slides, and then it'll activate B cells as well as CTLs and natural killer cells, which also release perforin granzyme to eventually contribute to the Hunter lesion pathology. And also monocytes of the innate immune system are also involved. Next slide, please. So if we have to go back to the etiology of an autoimmune disease, we know that patients with IC-BPS with Hunter's lesions have genetic susceptibility components such as HLA-DQ genes. The gender is also involved, as well as the external triggers, so stress, diet, all contributing to the formation of the Hunter lesion in the IC-BPS patients, as well as the random variables, which were the T cells and the B cells. Again, there are unknown factors because we still don't know the antigen. So next slide, please. In the future, we're going to try to figure out what percentages have these overlapping B cells, and then we're going to try to figure out what are the antigens that are driving this whole response. But again, recently we found that patients with IC-BPS with Hunter's lesions have a specific MHC, which is HLA-DQ, which is also shared with celiac disease. So patients with celiac disease also have HLA-DQ. Next slide, please. So in conclusion, there are a variety of different T cells involved in the Hunter lesion and the adaptive immune responses, but understanding the role of these cells and identifying the antigen can help us understand how the Hunter lesions actually form. And so we think that maybe IC-BPS with Hunter's lesions could be an autoimmune-like disease, and maybe it's even eventually will fall under an autoimmune disease category if we can identify the antigen that's driving the whole inflammatory response. Next slide, please. It really takes a village. Dr. Rob Moldwin was essential. He always provided us with all of the patient samples, and basically I just want to thank the patients as well. Without your help, we couldn't have discovered even that the HLA genes were involved as a genetic factor linked to the pathogenesis potentially. And also our entire group from the Feinstein, Cold Spring Harbor Labs, and the Broad Institute, and Wake Forest. And the CATS Innovation Award helped support part of this research. Thank you for your time.
Thank you very much, Joel. That was really great and really understandable. I mean, I think again like as far as take-home messages, these are really important. This is really important research to move forward with. These are findings that, you know, it's important to understand the basic pathology that's involved, that gives us an understanding of why these things are occurring. And then, of course, from the translational side, from the clinical end of things, we can use, hopefully down the road, a lot of these findings to target therapies. And that's really obviously the whole point of all this, is to help patients and develop new strategies of care. So, you know, kudos to you and all the groups, and to working with you, and just great work. Thank you so much.
Hi, good morning, good afternoon. I'm doing kind of more a fun lecture today. It's on lubricants, moisturizers, and dilators. These are really important tools that we have to help make sexual activity more comfortable. And I just want to go over some of them because it's a really big question. We all always get, you know, what kind of lube should I use? What can I do about my dryness? That kind of type stuff. And why does the physical therapy want me to use dilators? Well, hopefully this will explain a little bit. So why is this important? Decreased lubrication can lead to pain. Vaginal dryness can be constant, or it can come and go. It can cause pain, itching, tearing of the vulvovaginal tissue during sexual activity, as well as normal daily activities. I actually have a patient who every time she squats down to lift, you know, to do anything, housework, exercise, she actually tears right at the opening of her vulva. Up to 3 out of 4 women will experience painful intercourse or sexual activity at some point during their life. If left untreated, vaginal dryness, atrophy, painful sexual intercourse are chronic and progressive conditions that can last a lifetime. This can really profoundly negatively affect a woman's quality of life, as well as her quality of sexual health. Comfortable sexual activity requires adequate lubrication. So why do women feel dry? And this is anywhere from in late teens, early 20s, all the way through menopause. So some of the causes: stress, anxiety, depression. Our brains are really tied into our vaginas. So, you know, you can have some stress and it can really affect the pH, everything. Certain medical conditions, diabetes, autoimmune disorders, especially Sjogren's. You know, people have dry mouth, dry eyes, dry skin, dry vaginas. Perimenopause, that time anywhere like mid-30s until menopause, which on average is, you know, like around 52 or so. When your hormones are kind of going up and down, trying to figure out what they're going to do, it can lead to some vaginal dryness. Menopause, again, estrogen levels bottom out. Pregnancy, childbirth, and breastfeeding. So during pregnancy, your estrogen levels go down. It almost puts you like in a perimenopausal state. And then if women continue to breastfeed, they can just prolong that dryness afterwards. I mean, I have a lot of breastfeeding moms come in and they're just having horrible burning, itching, irritation. And it really is just from, you know, hormonal dryness. Anything that can imbalance the vaginal pH, semen, blood after your period, stress, anything. Chemotherapy and radiation. And there are over 350 medications that can add to vaginal dryness. Some of them, you know, cold and allergy medicine, it dries up your sinuses, it dries up your vagina. Certain antidepressants, ones we use all the time for vulvar pain, vaginal pain, bladder pains, the tricyclic antidepressants, the Elavil, the amitriptyline, nortriptyline. They actually have a mild antihistamine effect, and they really do cause dryness. The bladder medicines, the gotta go meds, dry up everything. And hormonal contraception, so birth control pill, NuvaRing, the patch, stuff like that. It's, you know, I have women that come in that are like 22, they're complaining really, really horrible vaginal dryness. You're thinking, why would a 22-year-old have this? No other past medical history. Well, she's been on the pill since she was 13. So that really does play into it. So who can benefit? So moisturizers and lubes shouldn't be limited to older and postmenopausal women. 17% of women from 18 to 50 will complain of vaginal dryness, and 56% of postmenopausal women will actually complain about vaginal dryness. And that is just what's reported. Lubricants are helpful during sexual activity for women of all ages, regardless of gender or partner. It really does not say anything about any kind of dysfunction, anything like that. It's almost like putting moisturizer in your face because, you know, you want to prevent wrinkles, you want to keep your skin nice and tight, you want to put moisturizer in your vagina too. Postpartum and lactating women, I think I hit on that, and cancer survivors, those undergoing active treatment like chemotherapy and radiation. So in recent years, there has been an explosion of different kinds of treatments. It really has come to the forefront. Again, this issue still remains underreported, undertreated. It's really important for patients to discuss this with their clinician as well as their partners. And sometimes even my boyfriend doesn't want me to use lube. He thinks it's a reflection on him. It doesn't reflect anything. And sometimes I say, bring him in. We'll have a talk about this. And you want to normalize the need for lubricants and moisturizers. Like, get out there, talk about it. What's the difference? Lubricant or moisturizer? How do I know what to use? So lubricants are short acting. You usually use them for any kind of sexual activity. It helps facilitate penetrative activity, manual stimulation, anything like that. There's different bases that I'll go into in a little bit, and these are estrogen and hormone free. Whereas moisturizers are longer acting. This is more of a maintenance therapy. Again, like the moisturizer on your face. You want to use this regularly, for example, 3 times a week. What moisturizers do, they replenish and maintain water content in the vagina and the vulva. It also helps maintain the pH of the vagina. Again, different bases, and these as well are estrogen and hormone free. So let's talk about lubes first. I just broke these down into the different types. So water-based lubes, these are the most common. These are a natural feel. They're not greasy, they don't stain. Rarely are people irritated. It's safe to use with latex polyurethane condoms, silicone dilators. However, with water-based lubes, they tend not to last as long as some of the other bases. Sometimes during any kind of sexual activity, you might need to reapply, especially if it's an extended time. Silicone-based, these are long-lasting. They're waterproof, so sometimes they're a little bit more difficult to remove. So some people need to remove it with like warm water and a mild soap. However, people that actually need extra lube, and if these can go in the shower, you can take these in the shower. It works like a
Don't slip.
yeah. Typically, they're not irritating. They're not sticky or tacky. They actually have a really nice, smooth feeling. It's safe to use with latex polyurethane condoms. You can't use it with silicone toys. Dilators, gynecological products, silicone works really, really well. And when they're used together, it actually breaks down the silicone. Uberlube is a really, really common one. We use that a lot. It's so good. If you think about using silicone, a lot of salons have this. So if you don't like the lube and it irritates you, you can always use it for frizzy hair. Runners use it for chafing. So you can use it during exercise, anything. Let's go. Hybrid, it's usually a water silicone mix. There is usually more water product than silicone. So you get the long lasting of the silicone, and it's also easier to clean up. This is also usually not irritating. Plant oil based, these are like avocado, olive oil, coconut oil, vitamin E oil. These are not condom compatible. They will break down condom, they will break down rubber, but it can be used with silicone. Usually not irritating unless somebody has an allergy. If you have a coconut allergy, don't use a coconut based lube. And sometimes these can be greasy and staining. Finally, they do make some petroleum based lubes. These are stuff like mineral oil, baby oil, Vaseline. You can't use these condoms, latex, silicone products. This actually changes the pH of the vagina. It makes it more alkaline, which then encourages bacterial growth. These are not recommended. So we want to stay away from any kind of petroleum-based lubes. Finally, over the last 3 to 5 years, CBD lubes have become so popular. I have a ton of patients that use CBD lubes. It's usually plant oil based. However, it can be water based, a hybrid base. If it is plant oil, just know you can't use it with condoms or silicone products. The added benefit of having a little bit of CBD in there is CBD can decrease stress, anxiety. So it's kind of a relaxation, pain relief. It can help, it's a muscle relaxant. It can help relax the pelvic floor if you have a tight pelvic floor. It's an anti-inflammatory. These can also, if it's an oil base, can be used as a massage oil. So you have tight hip flexors, you know, have tight piriformis muscles, you can actually use it as a massage oil. It's typically made with natural and organic ingredients. Just of note, CBD is not regulated by the FDA. So if it says it has something in there, you know, how do you know? How do you check? The best thing to do is to find a lube that has a third party that they verified how much CBD is really in there. You know, these are a little bit more expensive. You don't want to spend all that money and have no CBD in there. And just know, not one size fits all. You know, you might have a friend that said, I use the best CBD lube, it's great. And you use it and it doesn't work the same way. So sometimes you have to play around with them and find what one to work for you. Just some information. There is a site online. It's the Women's Health Interactive. They actually have a subsection that's called the Everything Lube Hub. They have independently tested tons, water-based, silicone-based. They tested the CBD lubes. They actually had 38 that they were going to test. They wound up only testing 8 because they couldn't independently verify how much CBD were in the claims of some of them. This part of this website is really good if you want any questions about any types of lubes. It gives a lot of information. Okay, moisturizers. So again, these are used for maintenance, usually 3 to 5 times a week. They benefit women with dryness, recurrent infection, regardless if they happen with or without sexual activity, if women who have pain and burning. Just of note, if your vaginal tissues have been dry for a while, you'll probably have some discharge and or burning with initial use. This is normal. It should clear up quickly. If it doesn't, speak with your clinician. Moisturizers do not take the place of topical estrogen replacement. Sometimes people try these first before they decide to use. I'm not talking about hormone replacement therapy by mouth. I'm talking about just the topicals. Ingredients matter. Make sure you read the labels. You want to avoid glycerins. That's a metabolic byproduct of sugar. So anything with a glycerin or has glycerin in it, it can actually promote yeast infections. Parabens, propylene glycol, these are something called humectants. They retain moisture or water. However, they are used in, say, antifreeze for propylene glycol. They are preservatives. Parabens, also a preservative. There's some question if it really disrupts your own natural hormones, thus maybe worsening dryness. You know, there's a whole bunch of questions out there about that. You want to, again, like I said before, mineral oil and petroleum and nonoxyl 9. So condoms, you just need to read the label to make sure you get them. You have to look a little bit without nonoxyl 9. It kills sperm. It also kills the good bacteria in the vagina. What you want to look for is hyaluronic acid. That's a great product that helps retain moisture. You know, we look for it on our face. Ophthalmologists use it in the eyes for dry eyes, and we use it all the time for vaginal. And again, the same thing, you might have to try a few before you find the one you like. Just a real quick note about pH and osmolality and why it's important when looking for a lube and a moisturizer. The pH of either one should match the vagina's pH. So you want to look for something 3.5 to 4.5. If it's too high, it makes it too alkaline. It acts like semen, so it can predispose you to bacterial vaginosis, other kind of infections, burning, that kind of stuff. Osmolality is the measurement of how much one substance is dissolved into another water-based substance. So the osmolality of the vagina is anywhere, you know, like 285, 290. A lube's osmolality, according to WHO standard, should be less than 380. However, after they made that, they realized that the majority of the products on the market, the osmolality is over 1200. So that's the WHO recommendation, that it be below 1200. Anything that is below 380, it is said that that lube meets or exceeds the standards. If it's below 1200, it's the recommendations of the WHO. Only water-based lubes have osmolality, so you won't find it for silicone or oil-based. What does it mean? So if something is hyperosmotic, the osmolality is too high, the lube is going to pull the moisture, the water, I'll use the word water, out of the vaginal cells, which makes them dry up, get shriveled up, more dryness, tearing, irritation, burning. If it's hypoosmotic, so too low, the cells of the vaginal tissue will actually pull the water out of the lube, After a while, they get so big, they burst. That can cause infection, again, irritation, burning. So we're looking for something that's nice and isoosmotic, just equal on both sides. And where do you find it? Honestly, like we find everything else, look online. When you look online, it should give of the lube the osmolality. Vaginal dilators, what's dilator therapy used for? It's used for desensitization around the vulva, stretching of the pelvic floor muscles, and it helps to keep that vaginal tissue elastic. Different conditions we use dilation for would be vestibulodynia, pelvic floor dysfunction, again, to stretch the muscles, atrophy, any kind of adhesions, either post-radiation or post-surgical, and especially women with vulvar dermatosis, lichen sclerosis, lichen planus. These conditions, if left untreated, eventually can cause some scarring down of the opening and lichen planus inside the vagina. So dilators are really important to help maintain that patency. How do you use them? Usually we tell people use them 4 to 5 times a week. You know, you put lube on, get in a comfortable position. A lot of patients say it feels like the dilator is falling out. I say, put a pillow there, read a book, watch TV, 15 minutes. And that's called containment. You don't need to move the dilator around. This isn't a wand. You just let it sit there for the desensitization and stretching. When you can painlessly insert the dilator, you can then go up to the next size. I don't tell patients just to jump to the next size, you know, dilate with the one that's comfortable for 3 to 5 minutes and then increase the size. Women also use vaginal dilators before any type of penetrative sexual activity. You can dilate for 3 to 5 minutes so that initial penetration isn't as burning, doesn't hurt as much, not as tight. This is a little cheat sheet. How do you know which lube or moisturizer to use? So if your dilator, dildo, vibrator is silicone, you can use water-based, oil-based. Hybrid only if it's a water-oil hybrid. So you want to stay away from silicone. If it's glass, you can use any of them. Rubber, water-based, silicone-based. Again, the hybrid, the water silicone hybrids, but not the oil-based. Plastic, anything. Latex, only water-based, silicone-based, or a water silicone hybrid. Polyurethane, anything, or these are condoms, and lambskin condoms, anything. What we want to do, essentially, this is great, this helps, it makes things more comfortable, but we really do want to treat the underlying cause. And this, we typically do topical hormone replacement. This is an estradiol cream. And you don't even need to put it all the way in your vagina. I usually tell people just a fingertip around the opening and just inside a little bit. We can get a compounded estradiol testosterone cream. There are testosterone receptors in the vulva. So sometimes estradiol cream is not enough and you need that compound. An estradiol ring, it just stays in the vagina and you change it every 3 months and it just lets out a certain amount of estradiol to help the vaginal walls. And also a tablet is usually used twice a week. With the estradiol ring and estradiol tablet, you don't have those variations every time you use it, like the cream where if you use an applicator twice a week, it's a steady state that you have. All of these, through different research studies, have shown that the serum, the blood level of estrogen is still below the postmenopausal level. It doesn't raise it. The black box warnings, a lot of them, they are on for the oral estrogen. You know, here and there are some people that aren't a candidate for estrogen, topical estradiol replacement. But again, you just speak to your clinician about that. Oral medication is Aspina. That's a SERM. I'm not really going to get into that. Intrarosa is a suppository that was approved and on the market in 2017. It is a synthetic DHEA. It's not an estrogen. It is a precursor hormone. So when it comes into contact with the vaginal wall, it stimulates your own production of estrogen and testosterone. And it helps improve the elasticity of the tissue and it regulates the pH. It appears to be as effective as low-dose estrogen. There is no black box warning on this for use in breast cancer patients because it is not considered an estrogen. And again, this is another one that the blood levels of circulating estrogen after using Intrarosa are below what a normal postmenopausal woman's estrogen levels are. Finally, in summary, sexual activity doesn't have to be painful. We do have stuff out there that you can use to help it more enjoyable, more pleasurable. However, you really do still need to treat the underlying cause, and there's many options to help make it sexual activity more pleasurable. Read labels. Don't put anything in your vagina without reading the label. Just because something is, quote, natural, it doesn't mean it goes in your vagina. Dilators can definitely help with intercourse and intimacy, and there are always new therapies emerging in the field of women's sexual health, which is such good news. And I've seen this progression from doing this for 20 plus years over the last 5 to 8 years. There really just has been an explosion. So we are no longer where we were in the 50s, where people were using Lysol for douching, for, moisture in their vagina. And the top left one, even, you can get a free booklet on doctor-approved methods of douching with Lysol. Thankfully, we are not there, and we have moved much further in this field. Thank you for your attention.
Is next on the program, and then I'll finish it off, and hopefully we'll have a little time for some questions. So Marina's, how long have you been working? How long have we been working together?
14, 15 years, give or take.
Yeah, it's got to be longer than that. I think, but so Marina, again, in the practice of seeing patients clinically herself, she's also really in charge of working on the program where we're doing installations. She's working with patients also on cyclosporin immunosuppressive protocols. So she's sort of the everything person, the person who's running the program with actually PTNS, posterior tibial nerve stimulation. So she's amazing, the breadth of work and skill set that she has. One thing that she definitely has a great deal of experience with, and as lectured on, it's going to be giving us some updates on, is how we treat the bladder locally. So for those patients who clearly have some problem in their bladder and it's not being derived elsewhere, how can we treat the bladder with various medications, installations, all that. So I'll let her take over from here, and I'll see you in 15, 20 minutes.
Okay.
Thanks, Marina.
Thank you. Let me just share my screen and I'll try to get going. So just, okay. Does it work? Let me see. Yeah, now. Sorry, I think I got it. So I promise, guys, that I'm not telepathic, but, and you'll see why, as you will see some slides, which I was very happily impressed with, that, as Dr. Moldwin mentioned prior, we're kind of sort of attached a lot during our work hours. So yeah, I borrowed this slide directly from the American Urological Association website. And yes, intravesical therapy is still considered to be a second line of treatment for patients with interstitial cystitis bladder pain syndrome, along with physical therapy, oral agents, and diet modifications. Conservative therapies should always come first, and all the oral agents, we always recommend to start at the lower doses with slowly increasing the dose of the medication. The intravesical agents can be tried in conjunction with oral agents or by themselves. In the last few years, phenotypic of interstitial cystitis bladder pain syndrome patients have become more talked about and more debatable. And as we know, majority of interstitial cystitis patients do not have visible discrepancies of the bladder surface. Only the small percentage of the patients are found to have Hunner lesions, and the Hunner lesion patients are usually older. They have more pain, smaller bladder capacity. Arguably, they are even more centric than interstitial cystitis patients without Hunner lesions. Intravesical installations can be both diagnostic and therapeutic in patients presenting with a gamut of symptoms that ranges from lower urinary tract symptoms, pelvic pain, nocturia, dyspareunia. Conservative therapies like physical therapy and oral agents have failed to accomplish the desirable outcome. Cystoscopic evaluation with administration of an installation would be a reasonable next step. As the pathogenesis of IC bladder pain syndrome proposes a wounded urothelium, which causes sensory and inflammatory reaction in the patient's body, delivery of medication directly into the bladder can achieve most desirable pain relief response in the patients. In patients presenting with pelvic pain, the installation that relieves pain will certainly suggest bladder origin. Cystoscopy can reveal presence or absence of Hana lesions. Most of the patients will experience pain with bladder feeling and many other symptoms with absence of visible changes in bladder lining. Intravesical installations can also be beneficial in slightly different aspect if, let's say, a clinician performs cystoscopic evaluation and finds diffuse inflammation in the bladder, which is impossible to control surgically. A series of intravesical installations would be reasonable to decrease the inflammation and subsequently provide the patient with cystoscopy with injections of Hana lesions and possible fulguration of Hana lesions, which inadvertently will lead to patients' ability to feel better, improve bladder capacity, and be more pain-free. These are some of the ingredients of intravesical installations. All of these agents individually are approved by FDA. However, in urology, the combinations of these agents remains to be off-label, which presents certain challenges, which I'll touch upon later. Intravesical agents can be used effectively in patients with sensitivities to oral medications, as I mentioned. Studies of individual ingredients instilled into the bladder do not show systemic absorption and can be safely used in conjunctions with oral agents. Treatment is initially started as weekly installations for 6 to 8 weeks and can vary in different patients based on their symptoms, presence or absence of Hana lesions, and the degree of inflammation. The combination of 2% lidocaine, which is a short-acting anesthetic, with sensorcaine will increase the duration of pain relief. For other patients, we use installation of lidocaine with sodium bicarbonate, and lately in our practice, we are finding more and more effect of improvement of pain in our patient population with actually lidocaine and sodium bicarbonate installation. The lidocaine comes in 2 flavors, 2 and 4%, and with 4% lidocaine installation, if mixed with sodium bicarbonate, it enhances absorption of lidocaine into the bladder lining and can cause systemic side effects, which are limited to a short duration of time, about 30 to 45 minutes, and consist of usually perioral numbness, dizziness, palpitation. The patients are usually kept in the office for that duration of time following the first installation, simply to observe for those mentioned adverse effects. Unfortunately, patients who do the installations at home, and I will mention it later, after the pandemic, the availability of many agents have become very difficult, and I am working with a couple of pharmacies in New York and Pennsylvania that are still able to provide our patients with necessary supplies. So lidocaine, as I mentioned, is AUA approved in AUA guidelines and is often used with heparin and other agents. Lidocaine and heparin are the most popular ingredients of an installation. Heparin is also mentioned in AUA guidelines, and it thought to mimic the GAG layer, glucosamine-aminoglycan layer of the bladder, and is involved in proliferation of fibroblasts and smooth muscles, as well as angiotensin. In some practices, pentosan polysulfate is used instead of heparin. The same principle of repair of the GAG layer is presumed with BPS. Steroids can decrease the inflammation and used in patients with Hana lesions. Sorry. DMSO remains the only FDA-approved intravesical agents. It possesses anti-inflammatory, analgesic, and muscle relaxant properties. The agent directly targets the urothelium and potentially enhances the absorption of other substances. DMSO is combined with sodium bicarbonate, heparin, gentamicin, and possibly triamcinolone. You can see on the slide the installation that we typically use in our practice. The common adverse effects of DMSO are garlic odor and sometimes worsening of lower urinary tract symptoms in the first 24 hours following the installation. The effect of DMSO therapy is not seen, unfortunately, for about 3 to 4 weeks. Do not get discouraged and just continue to plow along. Patients who are receiving DMSO are not immune from getting a urinary tract infection. Therefore, if irritative voiding symptoms, burning, lasts beyond 24 hours, do not hesitate to speak with your clinician and request the urine culture. It appears in the last few years in our practice, once again, that DMSO has gained a momentum and we're using more and more of it, as it does help many of our patients to achieve very reasonable pain relief from bladder pain syndrome. Some key points to remember. It's not recommended to retain an intravesical installation with sensorcaine and lidocaine for longer than 60 to 90 minutes, as it can cause urinary retention. Alkalinized lidocaine installation might cause adverse effects, and as I mentioned earlier, it is important to keep the volume of installation low, and it's important to observe the patient in the office. For patients with Connor lesions, additional steroid, and which is triamcinolone or salucortef, might be added. Many patients have to try more than one installation to achieve desirable effect. If one installation does not work, do not get discouraged. Patience is a key. Sometimes after doing a course of installations, patients become refractory to one particular installation, which after a discussion, we usually change the ingredients and continue to try other installations. Unfortunately, as many of previous speakers mentioned, interstitial cystitis bladder pain syndrome does not always exist in a vacuum, and it goes often coexists with other conditions such as vulvodynia, pelvic floor dysfunction, irritable bowel syndrome, fibromyalgia syndrome. It is important to incorporate heat or cold following an intravesical installation, bladder analgesics after intravesical installation, and lastly, in some patients who have diffused inflammation in the bladder, more than one installation per week might be performed. Something that I called rebound pain is simply the pain that occurs after putting the catheter through pelvic musculature that's already tight. Once again, if you would like to take a muscle relaxant or a warm bath before an installation, before coming to the office, that would be a reasonable thing to do. Retrograde installations. These are the installations that are received by patients who have exquisite urethral sensitivity. In some cases, after a few retrograde installations, it is possible for some patients to tolerate a smaller Foley catheter to actually deliver the installation into the bladder. Some patients in our practice use retrograde installations few times per day by delivering lower volumes of lidocaine gel in the urethra to help with predominantly urethral pain. When you do a retrograde installation, it is reasonable to stay in a lying position for about 15 to 20 minutes to ensure the absorption of the medication. Otherwise, as you understand, gravity will take its course and the installation might leak out. All right. Very new kid on the block. It's called UroAdapter. It's a very recent invention on the market, and I would love to introduce it to the audience. This gadget might save patients from actual catheterization to deliver an intravesical installation in the bladder. By attaching this adapter to the syringe filled with medication, one might administer the installation by putting the adapter into the urethral meatus and injecting the medication. Unfortunately, this product is European and does not have FDA approval in the United States just yet. Therefore, there is no coverage for the product. I put down on a slide a website. You can check out the prices for this product. There are few unanswered questions that I have about your adapter, which I would like to throw out to the audience. We don't necessarily know how much of the intravesical installation will be lost as the pressure in the urethra will push out the installation versus the conventional administration of intravesical installation in the bladder via Foley catheter. Will the effect of installation administered with your adapter be as desired in terms of pain relief? And you have to remember that with use of your adapter, first urinary bladder has to be emptied in order to avoid mixing the medication with residual urine in the bladder. For medication to reach the bladder, the bladder sphincter has to be completely relaxed, which is a very difficult task sometimes to achieve in patients with pelvic floor dysfunction. Also, would the delivery of medication with your adapter be equal in male and female patients simply because of the difference in male and female anatomy? So these are just few of the questions that I have, and I challenge the audience to ask questions. And if anyone has used this your adapter already, share their experiences with us. I would like to remind all that treatment of interstitial cystitis bladder pain syndrome remains a multifactorial and involves many disciplines. If chosen therapies do not work, it's reasonable to reevaluate the strategy. Some of you have overlapping conditions which were mentioned during other talks today. Do not hesitate to remind us that interstitial cystitis bladder pain syndrome does not always travel alone. IC has negative effects on quality of life, physiological well-being, psychological well-being, personal relationships, and general health. IC patients experience more pain, sleep deprivation, sexual dysfunction. Intravesical installations can be integral for reduction of symptoms and can be used by patients as weekly therapy or rescue treatments. Patients can learn to do installations in the comfort of their own home. Learning how to do the installations will require patients to come into the office and learn the technique of mixing the installation under the supervision of a registered nurse usually, or any other healthcare professional. Learning the techniques of clean intermittent catheterization and use of correct ingredients, which are of course prescribed by one of us. For patients with urethral pain, installations can be started retrograde. In many instances, doing self-installations can be empowering for patients, especially if they reside far from the practice. Other patients would simply like a chance to do rescue installations during flares without being attached to our office. This is a name of the study that many of my colleagues who have presented today are participating in. In the next few weeks, I might be asking some of the listeners to fill out a questionnaire for this study, as our sample size is relatively small. It's only 22 patients, 11 patients in office installation arm and 11 patients in a self-installation arm. As I already said many times, intravesical therapy is on AUA guidelines for treatment of interstitial cystitis bladder pain syndrome. However, there is little or no information available about the prevalence of self-installations patients and their experiences, barriers of learning, barriers of performing the installations. This is one of the first studies that focuses on benefits and challenges that patients in both groups are facing. Unfortunately, the small sample size is definitely a limitation of this study. We hypothesize that major benefits of self-installations will be rapid control of symptoms and symptom flares, more autonomy of the patients, cost effectiveness of installations being done at home before or after work, prior to important event, or simply before your child's baseball practice. Fewer office visits and more time to make other important appointments. Amongst barriers, the difficulty to perform installations due to some patients' poor dexterity, due to other medical conditions, fear of complications, and most importantly, the cost of the medications as they are not covered by the insurance. I think I have mentioned the insurance issues before, but once again, if you calculate the cost of traveling to the office, taking time from your family, and so on, perhaps cost of the medication and doing installations at home will offset that. On the final note, as I previously stated, same installations might not work for two different patients. Being able to do installations in the comfort of your own home is empowering. If and when the patient decides to move to self-installations, we will still be in touch always, and the patients are welcome to come in to the office as many times as they would like to ask us questions, do installations under our supervisions, and so on. Patients are welcome to bring their significant others and any family members who are interested in learning the technique and assisting their spouses or significant others. I guess it takes a village to do that. Well, you know the rest. A multidisciplinary approach to treatment of IC bladder pain syndrome is certainly a key, and that's where I'll stop. Thank you very much.
Thank you so much, Marina. That was wonderful. Really, the emphasis there, is in patient empowerment, especially with these self-therapy protocols. If we see so many patients throughout the day, it's really wonderful when patients learn themselves. There are barriers, there's no question about it, but to be able to take care of one's pain when you're in a flare, you're on vacation, and wherever in the world you are, if you have your equipment, you can work with these techniques, and it really again opens the world up. Let's move on to me. Actually, I have let me just get my screen share here, and we're going to talk about some sort of new concepts in the field, just to show you that the field of pelvic pain for men, for women, with pelvic pain, specifically with pelvic pain related to the bladder, pelvic floor, and all that, it's a field in motion. So let's just start her up here. Just to let you know, I love showing this slide to patients, to clinicians, just to show that, when I entered the field, which was something around this area, it was sort of sluggish, and you can see the explosion of research that has occurred in all these topics: interstitial cystitis, chronic prostatitis, vulvodynia. Everything seems to be really on the upswing, which is great to see. So a lot of that is due to the epidemiology that we know now. Once we thought this was a rare condition, these were rare conditions collectively. Now we know that they're much more common than they think. Therefore, more investigators are interested, more clinicians are aware of these conditions. And again, that's all shown in this graph on the amount of scientific activity going on. Just to give you an idea of something we're really proud of at our facility is our involvement with ESSIC, which is the International Society for the Study of bladder pain syndrome, interstitial cystitis. We just had a meeting in New York, and actually at one of our satellite facilities from Lenox Hill, which the meeting took place in Greenwich Village. And this was, again, an international meeting where we had over 17 countries represented, all dedicated to pelvic pain and taking care of IC patients clinically. We had lots of, not just urologists, not just urogynecologists, we had psychologists and anesthesiologists and basic science people really attending. You can see that bottom picture of this class of this a great turnout. All the faculty even came on their own dime to get to this meeting. So really there's enthusiasm, really people want to push this day forward, but you can see 38 lectures, 3 days, incredible experience, and we're hoping to keep that momentum going. Talking about some of the newer field, how do we advance the field? I mentioned in a previous talk that this was a condition that was very heterogeneous. We have some patients who have a lot of other things going on in the pelvis. There may be some patients who have bladder-based problems, some patients who have autoimmune issues, as Dr. Stern was talking about. There's some patients who have maybe defects in the bladder wall. And it may be different for different people. That's the difficulty that we have. We need to be able to better what's called phenotype. Every patient is like a fingerprint or a snowflake that is a little different. And that's why you may have to go through a gauntlet of different things, of different therapies before we get to something that's right for the individual. The key is trying to get there, and that's tough. But at the same time, there's a lot of research, as you saw in that graph. So there are a lot of targets, theoretically, that we can start to point towards, shoot for, and hopefully we'll hit the target with some of the new ideas, concepts in the field, and new strategies of care that will be discussed. Some of the new things that we're seeing more in the literature is a better understanding of how these symptoms of IC interrelate with other conditions. This is really important. Why? Because if you take a look at the middle of the slide over here, and you see all these different symptoms that we often see patients come in with: urgency, frequency, the pain, a lot of obstructive voiding means I can't get the urine out, or I never feel like I'm empty. And we can see that various conditions that we typically see in urological or urogynecological practice sort of overlap. So you can see OAB, overactive bladder. They do have the urgency, the frequency, but they don't have the pain. The IC has the urgency, frequency. They do have the pain. Is it a different type of urgency and frequency that we see in overactive bladder and IC? A little bit. And it's up to the clinician to be sensitized to this, to try to dissect the two apart. That's important. Now, the other side of this slide shows something called high-tone pelvic floor dysfunction. Those are patients, many of you have already been diagnosed as having pelvic floor dysfunction, pelvic myalgia. Either there's tenderness of the muscles, or the muscles are just not working properly. And that can give rise also to symptoms that overlap with them, with a lot of these conditions. Now, if you take a look at the arrows here. High-tone pelvic floor dysfunction can give you urinary frequency. It can make you feel like you're not emptying your bladder. It can give you pelvic pain. And that's why high-tone pelvic floor dysfunction is often overlooked in the evaluation of interstitial cystitis and bladder pain syndrome. And making matters more complicated is that high-tone pelvic floor dysfunction probably exists in about 80% of our patients who have IC-BPS. And in fact, high-tone pelvic floor dysfunction happens to be the big, often a very major component of the pain associated with this thing over here, CP-CPPS, that's chronic prostatitis, chronic pelvic pain syndromes in men. And it often happens to be another very common thing seen along with patients, female patients who present with vestibulodynia, vulvodynia, the different terminology that you'll hear, but basically vulvar pain. So this is a very important circle in our clinical practice. Unfortunately, that circle wasn't really being addressed for many, many years. Now people are realizing that it's out, and there's literature, and we'll go over some of that. Another very important issue is to, as I say, you got to keep your eye on the ball with patients' symptoms, because patients who come in with interstitial cystitis or prostatitis syndromes, et cetera, we always think of this as a pain condition. But remember in the early definitions that I discussed, okay, it's, yes, pain perceived to be related to the urinary bladder, but also those lower urinary tract symptoms. The typical symptom is that constant urgency. And typically we thought that always the symptoms of urgency, I gotta go all the time, are related to pain. In other words, I have pain, therefore I go to the bathroom a lot. And there's current research, and a lot of this has been done through the MAP, the Multidisciplinary Approaches to the Study of Chronic Pain Network, something we've been working with for the past probably close to 10 years now, really has shown that some patients who have IC aren't really bothered as much. They have the pain, but the thing that's really bothering them are the urinary symptoms. And when the problem here is that we need to pay more attention to this. When we do clinical studies on these conditions, we're very, very much focused on pain. Does your pain get better? Does your pain get better? But if I'm a patient and my focus is on, I just go to the bathroom constantly because I'm in discomfort, that may be the thing we should be following. So it's important in terms of follow-up of research, future research, we're beginning to get these understandings and what's affecting the quality of life. Something that we've developed here, this was, I have to give kudos to now Dr. Abel, who's was one of our medical students last year. Actually, she was working with me for several years in the lab and on clinical projects. This is something we developed, a pelvic pain map. And now those of you who are coming to the office are asked to give X's where it's hurting you, because some people can't verbalize exactly where their pain is. So this allows us, these are new, what we call instruments, to help guide us, help us to help you. Sometimes it's hard to describe where your pain is. And these are not perfect maps, but have been quite helpful. Another really important concept, and I have mentioned this a few times before in speaking with you this morning, is phenotyping. We know that not every patient who walks through the door with IC is the same. And sort of this is, we're writing, we've been writing chapters for Campbell's Urology, which is sort of read by all the urologists probably around the globe. But we've been writing the chapter on interstitial cystitis and related conditions. And the newest iteration is going to, the lead author is going to be Henry Lai, who's one of my wonderful colleagues at WashU in St. Louis. And this is a diagram that he came up with, which I thought was actually pretty good, actually excellent. We're putting in the chapter, which here you have it in the center here, IC-BPS patients, but there are these patients who are really bladder-centric, meaning that really their pain seems to be coming from the bladder, and that is that type of patient, these bladder-centric patients, we feel might be best at least to start off with therapy that's directed to the bladder. So for example, if you respond, often patients, we put a little anesthetic in the bladder. If your pain gets better, it seems that pain is coming from the bladder, maybe treating, like Marina was talking about, with intravesical agents. Agents we put into the bladder might be a good thing. Clearly, if you have a Hunter lesion, areas of inflammation, these patients might do quite well with burning the lesions, injecting with steroids. On the other hand, if it's a patient with IC who's really has a lot of pelvic floor tenderness on exam, hopefully people will check for it. Maybe we should be shunting those patients and getting them up and running with getting their pelvic floor looked into and treated, more supple, fewer trigger points. Maybe they have a lot less pain with that. And of course, there are many patients with centralized pain where it may not all be coming from the bladder. It may be some problem in the nervous system that brings the information to the brain. It even may be a problem with how the brain is processing the information, and therefore systemic agents might be better. This is more hypothetical but we do believe, at least clinically, this is probably a good initial approach, and then we'll subsort out patients even better, hopefully, in the future. The problem is that it's not that easy. it's not so easy because patients don't just come in, oh, I'm a bladder-centric patient, I'm a centralized patient, I'm a muscular pain patient. Often patients have all this stuff going on together. So that's why therapy often needs to be, patient has to be looked at as an individual, and therapy has to sort of be applied to address some of these problems. And for the sake, I mean, when we give clinical presentations to other, some of our colleagues, our clinical colleagues, we might show case presentations where patients come in with a whole variety of different symptoms and piece together, how can we take this puzzle and sort it out so we can get a good strategy of care organized for that individual. All right, so let's take a look at some of the sort of the neat therapies, I think, that I've just come across in the literature, some of which we're looking at, some of which I just think are sort of neat, and I'd love to take a closer look. This is one of the latter. I'd like to take a closer look at this. We've been suggesting TENS therapy, transcutaneous electrical nerve stimulation therapy, to patients for years. Often physical therapy, our pelvic floor physical therapists are key partners to help patients learn how to work with these units, and it can be really helpful. These are patches, as you can see on the top here. This is an interferential TENS unit, and electricity goes between these different patches, and you can see here these top few diagrams. I just wanted you to see the general concept of pulsing the therapies. There are different amplitudes, different frequencies, and so forth. Well, there's a different type of therapy that actually, to be honest, I was unaware of. It's called scrambler therapy, and this was presented in a review article in the New England Journal of Medicine just a few months ago. We presented it at our journal club, and it looks similar patches and all that, but it's a different type of energy that's applied, different spike patterns here. What's the difference? What's the big deal? It's just different energy, da 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 da. But here's the difference as pointed out in this article. Look at the main indications for TENS have typically been musculoskeletal pain. It's been used side by side with physiotherapy. But this scrambler type of therapy, changing the type of stimulation that the nerves are getting through these patches, seems to be really directed towards patients who have neuropathic pain, cancer pain, and even pain that have been resistant previously to opioid therapy. And as compared to TENS, where the therapy sort of lasts as long as you put it on. Now, we've had other patients, lots of patients who use it a lot, and the therapeutic effect might last much, much longer than just a few hours. It might last days, weeks. But the scrambler therapy, at least according to this particular article and some of the research being done in this, seems that even one therapy or two therapies or what have you might have a much, much longer lasting effect. So we'll take a look. My ears are perked up looking at this scrambler type therapy for the future for many patients. Another type of therapy that unfortunately we don't have at our center at this time, would love to maybe collaborate with other institutions. It's called extracorporeal shockwave therapy. Now, as urologists, we know this type of therapy because this is the type of therapy that's used to break up kidney stones. So the concept is there's a shockwave that's developed outside your body, extracorporeal, that burrows down. It's actually focused, sort of like a magnifying glass could focus light, but it's focused beneath the skin. Okay, it can go 1 centimeter down, 2 centimeters down, and on and on and on to break up that stone. But what happens if we use a different unit with lower energy, different types of the same it's still a shockwave therapy, but lesser doses, less different frequencies, and so forth. Maybe it has a different effect. And it appears that this type of therapy can enhance vascular, something called angiogenesis, development of a good vascular to supply to areas. It may actually have an impact on inflammatory processes at the focal point of where the shock therapy hits. And I just wanted to show you quickly a study that was very recently done. This is, I believe, from Taiwan, where they had female IC patients. They treated them for an 8-week interval, and after actually 12 months, they still saw some decrease in symptoms. That's called the ICSI, is the interstitial cystitis symptom index. They saw changes, decrease in frequency, voided volumes. They didn't see any change in actually how much the bladder can physically hold, but obviously things were improving for these patients. We need more studies. This is not a controlled study. There was no sham study done. Patients knew what they were getting, but it is some very interesting preliminary data to see. Some studies that are coming to our department are based upon something called the bowel-bladder connection. That means that the viscera are talking to each other, and the scientific terminology has been called visceral convergence. That means that the bladder and the bowel seem to connect themselves probably by more sophisticated mechanisms than just the nervous system, but we certainly know through the nervous system, when you have a bowel-related problem, often it's manifest as some difficulties with motor function over contraction, or changes in sensitivity of the bladder. And this particular trial, which we will hopefully be getting underway in the next month or two, involves putting a special medication directly into the rectum. Okay, so it'll be administered each night as a rectal foam. And the idea is that its effect on the bowel will have actually a benefit for those patients suffering from bladder-based pain. This is the formal name of the study on the bottom there. It's looking at IW 3300, rectally administered for 12 weeks to treat bladder pain. And you can find more about that trial on clinicaltrials.gov. So I recommend you take a look. And if you're in the office and if you're interested, we can discuss if you were be a candidate for that study. Another study that is going on right now, it's ongoing, is the use of Botox, botulinum toxin A, for the treatment of interstitial cystitis bladder pain syndrome symptoms. Botox is actually FDA approved for the treatment of overactive bladder. However, it's thought that it does have some anesthetic type properties. It does seem to affect the nerves that have a bearing on pain. And by giving 5 injections to the trigone, as you can see on this diagram over here, this is actually the most sensitive area of the bladder. It doesn't have a lot to do with the control of squeezing the urine out. Up here does. The hope is that it can change the degree of bladder-based symptoms, both pain and also patients who have the urgency and the frequency and all that. The biggest problem with this type of agent, of course, we worry about is could it relax the bladder as it does for the overactive bladder, and cause patients to have difficulty voiding or even need to use a catheter ultimately. That is of concern, and patients to even enter into this trial have to be willing to use a catheter if that would occur. But again, Botox is not FDA approved for the treatment of IC-BPS, but this study is looking to see if it might be effective therapy and ultimately receive FDA approval. So something that is ongoing. This would be done in the operating room. It is a double-blind, placebo-controlled study, so neither the patient nor we or any of the centers that are doing this would know what you're receiving. Ultimately, the patients would be offered what's called an open label trial, which means they know that they would be getting the medication. There's a lot of work that's being done as I keep on pushing this high tone pelvic floor dysfunction. And now people are really taking a real interest in this. This is a recent study that came out from MAP. We were part of that study looking at patients who came in with prostatitis syndromes, so male patients and male and female patients who had interstitial cystitis. And wow, look at this. As I mentioned, other studies showed the exact same thing, looking at a large number of patients, over 500, 81% of patients with these pain syndromes had evidence of pelvic floor dysfunction. And the more pain science you had, it was related to more pelvic pain, a worse quality of life, that's QOL, as you can see here on this bullet, and also more widespread pain. And it's also thought that if you have a ton of trigger points there, you also might be considered a centralized patient, a patient who have other nerve problems manifest in the spinal cord in the brain, and other agents, what are called centrally acting agents, like the gabapentins, the amitriptylines, and all that, might be helpful in those instances. I just wanted to give you, especially our patients who are seeing it routinely, just sort of an algorithm of, because I think pelvic floor pain is such an important thing to key in on and look at, because it's either a coexistent, it's what's called a comorbid condition to any bladder-based pain or prostate pain or whatever you have, that it's a target for us so frequently. And it's something that I think people really do need to identify routinely on their exam. So we do pick this up by history and physical examination. We ultimately make a diagnosis of pelvic floor myalgia, pelvic floor dysfunction, lots of different terms for it. And then we will typically, in our algorithm, we'll get patients hooked up with pelvic floor relaxation strategies, whether behavioral, certainly specialized physical therapy, heat application, constipation control, skeletal muscle relaxants, oral agents, transvaginal agents, transrectal agents, all sorts of stuff, to conservative things, in my opinion, that will calm things down. And in most people, that's pretty good. Okay, we can move on to other things after that. But for people who have sort of reached sort of a plateau where they're just not moving forward, we will often proceed with a nerve block, and we'll talk about that in a second, and or trigger point injections, actually putting a needle directly into those areas of pain, putting a little anesthetic there, usually a combination of lidocaine and bupivacaine, and see how the patients do. It helps diagnostically, because if we put the anesthetic right there and people, all of a sudden their pain goes away, now we know where the pain's coming from. So it has a diagnostic value to it. Also, for many patients, we give one injection, and for I'm sure there are many theories. I don't think we know the true answer to this, but we have many patients who have pain relief for literally days, weeks, months after these injections, and it seems to help. It helps the physical therapist along with their work. So again, something that we don't do with every patient, we do it selectively. And for those patients who it really does help, but they're just not getting a durable response, a long enough response to really make it clinically reasonable, practical to continue, we do consider Botox injections. Again, all off-label, just like Botox to the bladder for interstitial cystitis, but we have seen patients do better for extended periods of time, keeping in mind that Botox is not a, quote, anesthetic. It does have some anesthetic type properties, and more research, of course, in this field needs to be done. The reason why do we, just go straight to Botox? Patients very frequently ask us, because number one, I think it's very helpful, at least initially, to have an anesthetic to really define where the problem is, delivered to that area. It makes me feel more comfortable. And the bottom line is sometimes these nerve blocks and trigger point injections give pain relief just as long as the Botox. So why, do something that's much more expensive, may not be covered by insurance? It's just simpler for the patient. So we're patient advocates. This is where we typically do an injection, like when we do nerve blocks. So patients are, this is a male patient, obviously, in what's called lithotomy, legs are in stirrups, and we find this area and we give a little numbing medicine on the skin, and then numb up the nerve and then the muscles. These are the medicines we use, and you can see we use our really, really skinny needle to do these things with. So I'm not going to get into the risks and benefits. Those are other discussions. But for the sake of time, let's move on to anesthetic. We're going to go breeze through this because Marina really covered this topic. But I can tell you, putting anesthetics in the bladder and having patients self-administer has been really a wonderful thing. And as she alluded to, if we alkalinize those solutions, you're going to get the medicine absorbed much more avidly into the bladder wall, and hence, hopefully, maybe improvement in pain. We don't know, no head-to-head studies. But there is a company called Veneltix, and they're trying to get this little cocktail of medications FDA approved. We would love to see that, because it would mean open the door for patients, because then there might be kits for this. They can do it at home. It's all pre-mixed. It would make life so much simpler for our patients. So we are doing a study. We're just starting it now, looking at putting lidocaine in the bladder, putting heparin in the bladder. I told you heparin's a coating agent as well. Alkalinized solutions. So we're studying this right now, each individual component and the full solution as it would be mixed if it ultimately comes to market. So, kudos for Vaneltix to work on this. Very happy to see finally something coming of this, and I think this will enhance patient care. Again, you'll see this on clinicaltrials.gov. Something I thought was really cool, my buddies at Wake Forest, Steve Walker and Bob Evans, they see huge numbers of IC patients as well. Really wonderful people, and they're doing a lot of great research in the field. This is a study, one study I thought that was sort of cool. I show you. They're working on this special mat. It's you can see here on the bottom over here, it's a big mat. You lie down on it, and it applies an electromagnetic field to the body. This kind of technology is the same technology used to treat bone fractures, where they weren't healing. It dates back to the late 1970s, and it does seem to have some influence on the immune response and immune cell activities. They just started out looking at this, and some preliminary data they came up with that I sort of went through and just summarized it over here. Really small number of patients, but did see that most patients after 4 weeks of this did have some improvement, and greater or equal to 2 on a 0 to 10 scale at 4 weeks, and they had a significant decrease in the number of voids per day, symptom scores, and also quality of life improvement. So something really neat. They weren't looking at Hunter lesion patients, just so you know. They were looking at patients who actually had relatively normal bladder capacities, and patients who didn't seem to be as, quote, bladder centric. So, patients with more widespread difficulties. They might also have IBS and vulvodynia and chronic headaches and things like that, along with these their things. So really the take-home message today, I think, from all of our perspectives, there's a lot of stuff we can throw at you. Really what we're finding right now is we don't want to throw it all at you. We want to try to look at you as who you are, what your clinical presentation is, and try to create a plan that is hopefully effective and something that will work with you. And you have to also think about your work, your spouses, your everything that's out there in your life and how it drives with it. Also, I think I think you're going to see more of this in the future, that you're going to need more than one person taking care of you. Physiatrists, rheumatologists, pain management experts are very crucial. Psychologists and, a lot of people who spoke today are just really instrumental in really giving you a well-rounded care and get you up and running properly. So here's Hippocrates, who said a lot of things, good things, and we try to treat patients and think about his philosophy of care. What we've realized over the time is that it is a multifaceted condition. As I say, the phenotypic approach, everybody have fingerprints and snowflakes, everybody's different. I think we are working really hard. You saw all those different, the explosion of research that's going on in the field. We'd like to get more people charged up, more clinicians charged up to take care of people, so we can have coverage around the globe, of course. But really, I think, again, take-home messages here: we need more interdisciplinary care, multimodal care, more, what we'll say is precision medicine. That's really where we want to go. So I thank you very much for your attention. I think what we're going to do is, just for the sake of time, we're running a little over all of our technical difficulties. If somebody wants to, I don't know if anybody wants to, let me just stop sharing over here. I don't know who's left on our panel. It is now just a little after 1. I think we'll just spend a few minutes maybe just going over some questions, because I really love doing this for a little while. So I don't know who's on panel and with us. I know Jen's here with me. I see Joel there. Let's talk about, I'm just going to go through a few of these, and I'm sorry I'm not going to be able to get to Everybody today. Is Is it okay? I'll ask Marina, is it okay to take Uribel for IC pain?
Absolutely.
For what is Uribel?
Uribel,
So,
well, Uribel is, as many patients call it, it's a blue pill. It's a pill that makes urine very, very blue, but that, in essence, it's a combination of hyoscyamin, methylene blue, and it's geared towards relieving the pain in the bladder, and it has some antispasmodic properties. It is considered safer than taking the phenazopyridine, which is pyridium or azo, and our patients have many of our patients derive great benefit from using this medication either once a day or up to 4 times a day safely. Sometimes patients even take the Uribel prior to an installation.
yeah, I mean, I think I would definitely echo that, but one addition I was going to just say is, we usually use it. It's weird that, and I know you see the same thing, and Jen could chime in maybe also. There's some patients who do very well on pyridium, which is phenazopyridine, and some people who do well on Uribel. Both of them have anesthetic properties to them. And obviously that's why probably if you have a bladder-centric patient, you have a sensitive bladder surface. But do you see that some patients are responding to one versus the other?
Mm-hmm.
Yeah, I mean, it's interesting. I don't know what the reasoning for that is. Most of the patients that we work with also, we usually use these medicines for flares. We don't have a lot of patients because there's no data on long-term use with any of these medications. So we try to caution patients to, yeah, what's that?
Yeah, Phil Hanno actually wrote an article on phenazopyridine.
Right, for long-term use, yeah.
And it's fine. And, the pharmacist will say, don't take it over 3 days. That really is because it can mask the symptom of a UTI, and then you get a kidney infection. We're testing patients to see if they have a UTI when they're in a really bad flare. So, you check their livers, blood work, they get it from their PCP. It's really okay.
So here's another question we're going to go through. Hunter lesions. What about those of us with Hunter lesions and widespread pain? Oh yeah, as I say, they overlap. You can have a bladder-centric patient with Hunter lesions, and sure, they can have horrible pelvic floor-related problems. They can have migraine headaches. They can have, there's no question. I didn't mean to say that's why I drew those overlapping, more of a Venn diagram. Zen diagram, that would work. Venn diagram approach. For those patients, what we do find, interestingly, for those patients, unfortunately, who have such degree of pain coming from their bladder, that their bladders literally are just a thimble of a bladder. They just, and ultimately undergo cystectomy, removal of the bladder. Often a lot of the other sources of pelvic pain, for example, pelvic floor dysfunction, they often settle down, but that's not a given. It doesn't happen all the time. So yes, you absolutely can. And that's also why many patients with Hunter lesions will be treated with intravesical agents, but at the same time, they may be treated with agents that are such as gabapentin and amitriptyline and so forth, because again, we're treating 2 different types of pain that might be occurring. Let me just take a look over here. Let me ask, I don't know if, is Mary there? There's a question here, are TENS machines a good choice for pain relief? Yeah, I mean, I think I mentioned that scrambler therapy. I think it's great. I mean, our standard is to suggest TENS. TENS is just really easy. I mean, most of these units now you can get on the on Amazon. Yeah, it's pretty straightforward. It's easy to set up. If you have questions, you can also work with physical therapy to help set it up, and they've also been instrumental in helping our patients. So yeah, so TENS is really good. It's simple and a very simple approach. I could get into the whole, theory behind how TENS works, but again, we're going to try to move on to other questions. Let's talk about, can Valium I'm losing a lot to take a sip of my coffee there. Can Valium suppositories help urethral pain and vaginal atrophy? I'll let Jen do that one.
they don't necessarily treat vaginal atrophy. No, it's what?
No, I
Oh,
don't think vaginal
they don't,
atrophy. No, right.
They it's a muscle relax. We use it as a muscle relaxant. The side effect of a benzo with the muscle relaxant. If the urethral pain is maybe the little muscles around the urethra are spasming, sure. If it's something because your urethra is red on the inside, no. It's not good.
So I have a question for Joel. It's a takeoff of a question here. A patient is talking about herpetic infections and autoimmune disease. I'm going to rephrase this because herpes is not an autoimmune disease. However, the question I have for you based on this is, can a prior infection in the bladder, because this is always a question, we don't see any, there's not, even the microbiome studies, we're really not seeing a causative agent for patients with IC that's defined. Could a previous infection set up a local autoimmune response, something that would be, something that might be reflective of what you're seeing in some of your studies?
Yes, it actually could. There's a hypothesis called molecular mimicry, where something, it could be a bacterium or virus that almost looks like self, could trigger an autoimmune response. But you still need the autoreactive T cells and other B cells interacting with each other. But yes, in short, it could trigger and be an initiator.
Thank you. Great. Well, there you go. I mean, that's always of concern. Are we going to take maybe three more questions or so? And then unfortunately, I know everybody wants to get to their families or their food for lunch or whatever. How do you help? So Maria, let me ask you something. A patient who has they're getting installations in their bladder, but every time the catheter goes in, they're just miserable. I mean, are there some specific things that you do with patients that might mitigate some of their discomfort? Could you make some suggestions?
Aside from using some lidocaine gel intrauretrally prior to inserting the catheter, phenazopyridine is helpful for some patients. Once again, patients who are a little bit more pelvic pain centric, maybe taking a half of diazepam or doing a warm bath. But if the patient actually has urethral pain that all of us are struggling with, it becomes very difficult. And that's where part of my presentation will probably come in. Maybe start with retrograde installations and see if you can move the patient along. But urethral pain is a really tough one sometimes to work with.
You want to comment?
Just sometimes what we do, instead of using a regular size catheter, we go down as small as an 8. We use an 8 or a 10, and with the lidocaine gel, and it really seems to be a little. It's almost on your basis, Marina, like with the retrograde. It's just so tiny, and then you can just like coat the urethra on the way out with the medication.
The downside of that is that some of the agents that we put in, the gels,
I think they're a 10.
Yeah, that's the problem. Yeah, so it's just more logistical issue.
The gel presents a problem, and 8 and 10 are technically pediatric size catheters. So in common urological practice, you don't have them available.
No, we order them for those patients that are that have urethral pain.
So, but again, I think these retrograde installations were, and I think your comments on the trying to calm the pelvic floor, because a lot of the difficulties and the big difficulties we've even had with the retrograde installations is that patients clamp down and we can't get the installations in. So it's really a lot. And that's why this conference is so awesome, because there are so many breathing techniques that you can use to calm the pelvic floor down and all that, because breathing is really important. Here's a good question about rebound pain. And I think actually this speaks to the question on rebound pain. I think the question involves putting the catheter in and stuff like that. We don't really know what rebound pain is. Like patients do great with the catheterization, and then they get this kind of discomfort, or like the next day is really bad. And nobody really knows. I don't really have a totally good understanding of why that occurs with some patients. I mean, I think I don't know what you guys think. I think it probably has to do with sort of why pain, like sexual pain, patients often complain, oh, I have horrible, I can get through, sex is fine, the next day I'm in misery. I think a lot of it has to do with, the musculo, the pelvic floor dysfunction that often occurs along with it, but I'm sure there must be other mechanisms.
Sometimes people hold their installations for 2 hours,
Yeah.
90 to 120 minutes, and maybe they're just not used to holding it that much, so
Yeah.
they actually get pain. It's almost like,
but I wonder if we could avoid this. Now you're hearing the internal talk that we do when you're not in the office, right? I wonder if like taking like a peridium beforehand,
That's
maybe,
yeah,
or
100%.
and continuing, or even like a diazepam suppositor or oral, whatever, a muscle relaxant or something like that might, again, mitigate some of these problems. So I think that's sort of a cool thing. I'm going to do one more question, and I apologize. At one point, maybe we'll do like just a question answer day. We've done that before, which is sort of fun. This is a great question, and it really is a great question. What's the deal between recurring urinary tract infections and ICVPS? So I don't know how people are going to try. I'm going to start this one off and see what you guys think. So just because you have IC, okay, so just because you have bladder pain does not mean you can't get a urinary tract infection. And urinary tract infections can be recurrent. And just like you could have overactive bladder and have IC, just like you can have, I hate to say, bladder cancer. We do have some patients with bladder cancer. So you can have different pathologies there. That's the way it is. That's the way we try to dissect things apart. But yeah, people do get recurring infections. The problem here is now you have a sensitive bladder, you get an infection, all hell breaks loose. It puts you into a flare, your pelvic floor starts to get worse. So it is really, really important when we have those patients who do have that baseline IC problem, to try to try to push the recurring urinary tract infections to the side. So very frequently, we get into the realm of topical estrogen therapy. We are working with, of course, keeping our patients well hydrated. We're working with prophylactic protocols, whether it be methenamine or nitrofurantoin or sulfamet, whatever, oftentimes to try to keep the infections at bay. That way we get a better feel for what are your underlying symptoms, and we don't have to deal with the recurring infection. So it's really a great question. It's a very important clinical problem that we have. And why the field is, it can be frustrating for both clinicians and patients.
I just have a question for Joel.
Oh.
Joel, can you hear me? Oh.
Yeah.
So if somebody has these recurrent infections, does that somehow set off their immune response to maybe, and then they have more pain and, maybe it's like that kind of type thing, not just because they're bladder sensitive, but it actually does something?
Definitely. So it could actually, it may not be specific towards one particular answer, but it could definitely activate and enhance the pain just from all the factors that are being released by the immune cells in that confined area. Absolutely.
I'm surprised you did not discuss diet. Yeah, we gave a full lecture on diet a few months ago. Yeah, so I sort of sideswiped
so many
that.
topics.
Yeah, we can only get to so much. And I apologize to the guys out there. I mean, a lot of the guys, of course, about 2 million men estimated to be with IC in the United States. We did sort of briefly discuss sort of a side issue, pelvic floor dysfunctions that can we always see in men, and the male patients that I see, many of whom have Hunter lesions or just have the basic symptoms of IC. We will hopefully in the future develop a specific lecture, a bunch of lectures dedicated. We have done that in the past. Today we stayed with probably more with female patients.
Well, I would like to say lube is good for men too.
Lube's good for men too.
So there you go.
Okay. Okay. I think we pretty much have a wrap here. I really appreciate, I have to thank the faculty for coming, joining, everybody joining together. This is a great group of individuals. It is a blessing to work with everybody here today. This faculty is incredible, and they all, I'm sure, have other things to do on their weekend and they're out. and the patient and patients and everybody who's participating today, the patients and their loved ones, hopefully, who might be listening into. I hope this is helpful. It gives you at least some basis on topics that it's just hard to discuss in these little times that we can spend in the office together. So again, have a great rest of your day, and we'll plan on doing this again in the near future. Bye-bye now.
Bye.